clerk will call the roll.
Click.
Present.
Jaton.
Here.
Johnson.
Here.
Oliverson.
Here.
Price. Tinderholt.
Good morning, everyone. Quorum is present. We've got a pretty long agenda today, and I'm hopeful that we can move through all these bills in an efficient manner. As a reminder, if there's anyone who wishes to testify on any of the bills we'll be hearing today, you must register on the electronic witness affirmation kiosk located outside the hearing room before you testify and indicate each bill that you would like to testify on. As per the committee posting, I will limit testimony time and the number of witnesses to ensure consideration of posted and pending business, especially if testimony would cause the hearing to extend into the next calendar day. I would like to inform everyone that the public comment portal opened when the hearing was posted on Wednesday afternoon. Any Texas resident is welcome to offer their comments on the portal. Each member of the committee is able to view the comments as they are posted. The comments will be posted and available on each bill's website after the portal is closed. Okay, we are going to begin our public testimony. The chair lays out House Bill 2166 and recognizes Representative Guerra to explain the bill.
Thank you, Madam Chair, and members and colleagues for allowing me to lay out House Bill 2166. I'd like to give some background and context to this legislation. Kind of hearing some background. It's throwing me off a little bit, I apologize. This bill designates March 4th as COVID Heroes and Memorial Day for the next 10 years. March 4th, 2020 was the first confirmed case of COVID in Texas. The purpose of this bill is to honor and commemorate those who lost their lives to COVID. Most of us all lost someone we know to COVID. This bill also recognizes those workers who work tirelessly and put their lives in harm's way to keep Texans safe during a time of unprecedented crisis. People like medical providers, first responders, law enforcement personnel, retail essential workers, federal essential workers, state and local government workers, and so many other heroes. This bill is a small gesture to honor a great sacrifice by so many. Chairwoman, I respectfully request the right to close.
Question, members? All righty. I don't show that we've got any witnesses that have signed up to testify. Is there anyone who wishes to testify on, for, or against House Bill 2166? Chair recognizes Representative Guerra to close.
Madam Chair and colleagues, thank you for consideration of this bill. I think I could venture to say that probably everyone knows somebody who passed away, dear family members, dear friends, and so many others that are so missed. And we thank you, members, and I hope you sincerely appreciate this bill and ask for your favorable vote. Thank you.
Thank you. If there's no objection, House Bill 2166 will be left pending. The chair hears no objection. House Bill 2166 is left pending without objection. The chair lays out House Bill 4960 and recognizes Representative Patterson to explain the bill.
Thank you, Madam Chair. Thank you for the opportunity to be here today, and esteemed colleagues on the committee. This is a very simple bill that could have a huge impact for families across Texas dealing with pediatric cancer. And so I have some constituents here this morning with us, the Denton family. I'm not going to tell their story. They're going to do that. But specifically, House Bill 4960. Oh, and I'm sorry, there is a committee substitute.
I'm sorry, the chair offers a complete committee substitute. Members, are there any questions for Representative Patterson on this? Okay, go ahead.
Okay. Specifically, this bill seeks to offer a simple disclosure that the treatment that a child may receive when they have pediatric cancer could limit their ability to start a family later. And so that's basically what this bill does. It's a very simple bill, but could have a huge impact. We have the Denton family here. Would love for them to share their story with you. Other than that, I'd be happy to take any questions that you may have.
Questions, members? Chair recognizes Representative Jones of Houston, and Representative Campos is present. And Representative Smith is also present. Okay, we will begin our public testimony and reserve your right to close. The chair calls Noah Denton. Up next on deck will be Melinda Denton, and then Jason Denton. I have you registered as Noah Denton, and you're representing yourself and you're for the bill, is that correct?
Yes.
Okay, please begin your testimony.
My name is Noah Denton. I'm a 17-year-old who goes to Lone Star High School. When I was 15, I was diagnosed with Ewing sarcoma. It is a type of bone cancer. Oh. Do you need me to repeat what I said? Okay, sorry. I had really good doctors that did a lot of research and gave me good treatments to save my life. But in the process of saving my life, I might have lost my ability to create life later on, if that's something that I choose to do. So it's something that I didn't know when I was at the beginning of my treatment. And I guess all I want to say is that's something I would, I would want my parents to know before that happens, and other people going through my situation, I would want them to have known that too.
Members, any questions? Thanks for sharing your story. I'm glad you're here today. I presume that you're in remission and doing well now?
Yes, ma'am.
That's awesome. Thanks for being here.
Thank you.
Chair calls Melinda Denton, followed by Jason Denton. Melinda Denton. I show you registered as Melinda Denton, and you're representing yourself and you're for the bill, is that correct?
I am.
Please begin your testimony.
I changed my mind, but I will do it anyway because I love my son Noah, and I want to do this for all Texas kids. We were thrown into a whirlwind the day that Noah was diagnosed with cancer, and the kind of cancer he was diagnosed with. You don't get to leave the hospital. You stay in the hospital. And by the time your biopsy comes back, your surgery is scheduled to have a double port placed in your chest because you need that much chemo. It takes 2 ports. And they tell you everything you're going to go through. And it's overwhelming because that gets placed the day after, within hours of finding out, and hours after your port's placed, chemo starts, all in a matter of days. And then your chemo treatments are in hospital. So by the time you leave the hospital, you leave to a new world. So my hope would be to eliminate some of the chaos that goes along with the overwhelm feeling of becoming a family going through cancer. So adding this language and opportunity for parents to hear that there are opportunities for us for reproductive cell storage. That would be something that would be beneficial for the generation ahead, because they are the next generation and they are fighting for their lives. And if they can have this one thing, that would be so incredible. Thank you for considering adding this language. Thank you.
All right, thank you. Chair calls Jason Denton. I show you registered as Jason Denton. You're representing yourself and you're for the bill, is that correct?
Yes, ma'am.
All righty, please begin.
Madam Chair, honorable committee members, and fellow Texans, thank you for the opportunity to speak on behalf of HB 4960. I stand before you today as a concerned dad. 791 days ago, my son Noah, at 15 years of age, was diagnosed with a rare bone cancer. And upon hearing the announcement that our son had this deadly disease, we quickly segued into treatment options. In these tender moments, it was as if we were talking about performing life-saving measures such as CPR, and there was no mention of the potential side effects that the chemo has, such as permanent sterilization. When we discovered this fact, it was likely too late, but we did make attempts and failed to preserve any reproductive cells for my son. There are about 2,000 Texans under the age of 20 that are diagnosed with cancer each year, and like our son, many will be potentially sterilized without their understanding. With today's technology, readily available access to reproductive storage, there's no need for thousands of Texans to be rendered unable to reproduce each year. Storage of reproductive cells now averages about $25 a month, and also there are nonprofits out there that are willing to pay for the storage for oncology patients today. Everyone knows that cigarettes are bad. If you look on the box, there's a Surgeon General's warning on it. Same goes with alcohol. There's a warning required by law. I believe that's because we require these warnings because we want to be an informed society. HB 4960 will inform families of the risks involved with chemo and give them the opportunity to make informed decisions for future of their generations. So thank you, committee members, for considering protecting teenage cancer patients and their future. Thank you, Representative Patterson, for bringing about this important issue to the attention to the Texas legislature.
Questions, members? Thank you for your testimony.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 4960? The chair recognizes Representative Patterson to close.
Thank you, Madam Chair. Thank you so much for giving us the opportunity to lay this bill out. I'd be happy to answer any questions that you have.
Question, members? All righty.
Thank you.
The committee substitute is withdrawn, and if there's no objection, House Bill 4960 will be left pending. The chair hears no objection. House Bill 4960 is left pending without objection. The chair lays out House Bill 2512 and recognizes Representative Morrison to explain the bill. And it looks like you have got a committee substitute.
Yes, ma'am, I do. Thank you.
The chair offers a complete committee substitute. Members, are there questions for Representative Morrison? You can go ahead.
Thank you, Madam Chairman and members, for the opportunity to lay out House Bill 2512. This is relating to the licensing and regulation of athletic trainers. The current Athletic Training Practice Act in the state of Texas has not been updated since 1999. The committee substitute to House Bill 2512 updates the definition of athletic training to best reflect modern practices of the profession without expanding the scope of practice. This revised language establishes more employment opportunities and allows access of physically active individuals to the services of an athletic trainer under the direction of a physician. the Texas State Athletic Trainers Association, TSATA, believe these changes will make the practice of athletic training less restrictive for licensed athletic trainers in all work settings, such as the Tesla factory, the United States Air Force, fire departments, and many others. We have a member here from TSATA Board of Directors, Dennis Hart, who is here to testify in support of the bill and to answer any questions that you might have.
Questions, members? All righty, we'll reserve your right to close.
Thank you.
Chair calls Dennis Hart. I show you registered as Dennis Hart, and you're representing the Texas State Athletic Trainers Association and yourself, and you're for the bill, is that correct?
That's correct.
Please begin.
Madam Chair and distinguished committee members, thank you for the opportunity to be here today. I am Dennis Hart, a licensed athletic trainer, and I'm testifying on behalf of the Texas State Athletic Trainers Association, some 2,700 members strong, and myself in support of the committee substitute House Bill 2512. I've practiced athletic training for over 50 years in the secondary schools and physician outreach settings. About 4 months ago, on January 2nd, football fans across the entire nation witnessed Buffalo Bill Damar Hamlin make a tackle, stand to his feet, and then collapse. Those of us who watched this event live saw the athletic trainer assess the condition as cardiac arrest and immediately activate the emergency action plan. We saw the athletic trainer signal to his colleague to bring the AED while cutting off Damar's jersey and equipment. CPR and defibrillation occurred within 4 minutes. We all wondered if Damar would survive. Today, we know Damar Hamlin's life was saved that night by the athletic trainers and the Buffalo Bills medical team. Damar was cleared by his physicians to return to full activity last week. You will find many news stories of athletic trainers recognized for their life-saving efforts of students and coaches on the TSATA.com website. House Bill 2512 Committee Substitute does not change the practice or scope of athletic trainers. This bill's intent is to update and modernize the language of our Practice Act, an act that has not been updated since 1999. This bill enables athletic trainers to serve the physically active individuals as established under the direction of a physician. Athletic trainers are trained as first responders and care to provide emergency care and to prevent, assess and treat injuries and medical conditions for people in work, play, and life, including participants of sports activities and recreational activities, industrial workers, military service members, and public servants. We are most appreciative of the staff at TDLR as they provide guidance as this bill was drafted. The TDLR is a valued partner who provides oversight for the athletic trainers in Texas. Athletic trainers are licensed healthcare professionals who are qualified to serve the physically active individuals under physician's direction. The bill lists the domains of practice set forth by the Board of Certification for Athletic Trainers, a national body that sets licensing standards for our industry. Athletic trainers collaborate and work with the other healthcare professionals to provide the best healthcare possible. House Bill 2512 Committee Substitute does not change what athletic trainers do, but rather provide access to the knowledge and skills of licensed athletic trainers to the physically active Texans when directed by a physician. I respectfully ask you to favorably report House Bill 2512
committee substitute out of committee, and I'm happy to answer any of your questions.
Questions, members? Representative Jones?
I'm a former athlete, and I've had my career saved a whole bunch of times by licensed athletic trainers.
Right.
So I definitely appreciate what you do. I had
Thank you.
a tear in my meniscus, and I was back running in 3 days. So that was great training. So my question specifically, though, is what exactly, like in one sentence or two sentences, how does this change it?
Well, what this does is it just modernizes the language of what we do and describe in our rules, and our practice is that we are adding physical activity. And I'm going to give you an example. I know you said one sentence, and I'm sorry. But when we talk about exercise or physical activity and we talk about athletic, an example would be the Houston Ballet performers has an athletic trainer that takes care of them. They're not defined as an athlete, they're defined as a performer. They are physically active, and they do actively engage in exercise. And so athletic trainers, by the physician's direction, would be able to be enhanced in their scope of practice, be able to practice.
So I guess in a nutshell, for me, just make sure I understand it, because I think I support this bill. So you're saying that what happened with Damar Hamlin, with what the licensed athletic trainer did at that moment in time, currently wasn't in the definition?
No, it's in the definition.
It was in the definition?
Yes, it's already in the scope of practice. It does not change the scope of practice. Emergency care is one of the domains of athletic training,
So
in practice and education.
So you put the physical, I think you say the physical activity,
Yes,
like, so like maybe golf or,
like you. If you were to be recreationally running and you would be, say, in a road race out, and you had an injury or a condition that you would need care for, you would be under the new terms, being physically active or exercising, and that would fit into the new two terms, physically active and exercise.
okay, thank you. You helped clear it up. I appreciate it.
Thank you.
Representative Price?
Dennis, good morning. Thank you for being here. I just wanted to thank you again for coming to public health hearings since at least 2011 that I remember. So you're very kind to make the trip from Mesquite, and we're glad to see you this morning. Thank you.
Always a pleasure.
Other questions, members? All righty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 2512? Chair recognizes Representative Morrison to close.
Thank you, Madam Chair and members. And I think from what Dennis was talking about too, it seems like this bill does not have a lot of change, but it's just small changes that actually shows where the athletic trainers are today. I think when we always have thought about athletic trainers, it was just on the field in sports, and that's not what it is anymore. They are so active in other physically active areas and working now, like even talking about the Tesla factory. You've got people that if they have an injury, they can be helped. If you talk about United States Air Force, I mean, they are working with them a lot. Fire departments and many other venues, that this does not change the scope of practice. It just changes to show what this is now that it didn't used to be, but with the way we thought about it. And so I hope to have your favorable consideration. I'll answer any questions if anyone has anything.
Questions, members? All righty, thank
All
you.
right, thank you.
The committee substitute is withdrawn if there's no objection. House Bill 2512 will be left pending. The chair hears no objection. House Bill 2512 is left pending without objection. The chair lays out House Bill 1340 and recognizes Representative Frank to explain the bill.
Thank you very much. Excuse me. Thank you very much, Chair Click and committee members. I appreciate the opportunity to lay out House Bill 1340 to you today, addressing the licensing of veteran physicians and veteran nurses wishing to remain in Texas after their military career is over. If this bill sounds familiar to some of y'all that have been on the committee a while, it is. It passed this committee and the House and got through the Senate committee and died an untimely death with a number of other bills on the intent calendar that some of y'all may have enjoyed as well. Y'all know, and I know you have addressed in many ways, the physician and nursing shortages, especially in the rural areas of the state. What you may not know is Texas is also the proud home of the largest number of military installations in the country. Currently, federal law exempts licensed active duty medical personnel from state occupational license requirements. However, these exemptions lapse once a provider, or once a nurse or a doctor leaves active duty military service. What HB 1340 does is allows physicians and nurses in good standing to waive into the Texas license and continue to practice in Texas once they leave active duty service on a couple of conditions. First, they have to have served in the military installation for at least a year. They also have to pledge to provide their services to medically underserved areas of the state. The only change from this year to last is we have made sure that those who are dishonorably discharged cannot take advantage of this licensing. So with that, be happy to answer any questions.
Representative Alverson.
Thank you, Madam Chair. I appreciate it. Chairman Frank, I appreciate this bill, and I do remember this bill. But I did have a question for you. So your bill actually exempts them from having to pass the medical jurisprudence exam, which is basically, you know, I mean, that it may sound important, may not sound important, but basically that's the test that is given to anyone who's seeking a medical license in Texas, that just familiarizes them and shows that they have knowledge about what the Medical Practice Act in Texas says you can and cannot do. I would think for somebody practicing exclusively on a military base that may not be familiar with Texas law regarding certain issues that could be connected to the practice of medicine, it would be important for them to do that. Is there a reason why we just opted them out of that entirely?
Well, no, they have to have a medical license from another state. Is that not something they would,
well, the jurisprudence exam is specifically there to make sure, it just sort of talks about, you know, the Medical Practice Act in Texas. I mean, obviously, you know, as you know, I mean, the Medical Practice Act in states may encourage or discourage different practices, and may have slightly different standards. I mean, a lot of it overlaps, but, you know, this is the thing we always worry about when we talk about these compacts is, are they following state law? Because there are certain issues that state has taken a strong stance on, and we want to make sure that the medical community knows what those things are.
Right. And I guess that is ultimately the question. I guess we, you know, one of these providers has a license, they've moved here, and the question is, do we force them to wait 6 months, a year to take that?
Well, I mean, that could be given on the same day.
Okay.
I mean, they could basically come in and do it and be done. It's just a thought. I mean, especially as states are going in different directions now on a variety of issues, I think it's important that these practitioners know what you can and can't do in the state of Texas versus the state of California, for example.
For example.
Okay. Anyway, just a thought. Yeah.
Do you know if compact licensure, whether that's required for those or not?
The jurisprudence exam? Mm-hmm. I'm not sure, honestly. I know that it says that they have to comply with, or at least some of the compacts. The ones that we pass out of this committee are the ones that typically have specific language requiring that they be in compliance with the Practice Act for that state that they're practicing in. That's always one of the things I look at, is to make sure that the compact license doesn't supersede state law.
Right, but you know, you were talking specifically about a medical license, and I didn't know, because
if they have to take the jurisprudence exam, I don't know. I don't know on that.
Something worth.
Right, I'm happy to look at.
But I mean, I know the medical board's here if we wanted to ask them, but I think it's one of those things where the test could, I mean, it's just a multiple choice test. It's not like it's an oral exam or do 50 push-ups in 2 minutes or something like that. I mean, it's just,
Right.
It could just be given and passed. It's basically there just to make sure that they know what the Medical Practice Act says in our state.
Well, I'm happy to do that. I'm trying to thread the needle between making sure we've got obviously physicians who know what they're doing, but also for folks who are wanting to retire, not to put undue burden, because sometimes if it takes 6 months or a year to get your medical license, your Texas medical license, and you're licensed in another state, it means the person's not retiring here, and then we lose that person. So
I totally want to
certainly
expedite
certainly
that
happy
too.
to, yeah, certainly happy
Yeah.
to look at adding that either to the committee sub or more preferably on the floor.
Absolutely.
We can.
Well, I mean, Madam Chair, it may be worth asking the medical board.
Right. We'll ask the medical board to come up and
Okay.
see what they say on that, to better guide you. Any other questions, members, for Representative Frank? Okay.
All right, if I could reserve.
We'll
our-
reserve your right to close. Chair calls Stephen Carlton. Good morning, Mr. Carlton. I show you registered with the Texas Medical Board and you're neutral on the issue.
Yes.
What about compact medical licenses? and
Yes, we do
jurisprudence?
require our compact licensees to take the JP exam.
Okay. Representative Alverson?
Thank you, Madam Chair. So Brent, I appreciate you being here today. So this would propose to exempt these folks from the JP exam. What is could you just briefly explain to the committee members, what is the JP exam? What does it cover? How long is it? How complicated is it? I mean, just kind of walk us through that process. Is it something that could be given quickly and in a time-efficient manner to accommodate what Chairman Frank's trying to do?
Yes, you kind of laid it out pretty well yourself. It's just to make sure that all of our licensees understand the requirements in Texas for the Medical Practice Act, our statutes and rules. It covers things like reporting requirements, medical record keeping, things of that nature. So it is something that does vary a little bit from state to state. And we have had individuals that have, kind of thought, oh, well, I did it this way in another state, or I did it this way in the military. I thought that's the way we would do it here. And so just to make sure that they understand what those requirements are. It is something that can be taken kind of at the applicant's leisure. They take it online. We do have a study guide that they can use. They're not required to do that, but it's
So
not
you can
uncommon.
take it online, Brent?
Yes, that's correct. You
Okay.
certainly don't have to wait a long period of time to take it. There are people that'll take it over the course of a weekend.
Okay, yeah, great. So I think you answered my question. That's kind of what I was thinking. It wasn't a very complicated process, but I think it's a very necessary one for somebody who's maybe not familiar with the laws of the state and the Medical Practice Act specifically, to be familiar with that. Thank you.
Yes,
Other questions, members? Thank you.
thank you.
Is there anyone else wishing to testify on, for, or against House Bill 1340? Chair recognizes Representative Franks to close.
Thank you very much. Obviously happy to look at getting that added. It seems to make sense and really, again, doesn't have some of the undue delays that causes people not to retire here and not to serve folks here. So I'd appreciate your favorable consideration. We'll either get that added, obviously I would prefer to add it on the floor given the late time, but can do it however the committee desires. So with that, if you don't have any other questions, I'd close.
All righty, thank you.
Thank you very much, Chairman.
If there's no objection, House Bill 1340 will be left pending. The chair hears no objection. House Bill 1340 is left pending without objection. The chair lays out House Bill 2424 and recognizes Representative Romero to explain the bill.
Good morning, Chairwoman Click and committee members.
And you've got a complete committee substitute.
Thank you.
Is that correct?
Correct.
Okay, the chair lays out the committee substitute. And please
Thank you,
begin.
Chairman. Members, thank you for allowing me the opportunity to lay out committee substitute for House Bill 2424. Texas law establishes health and safety standards for the construction and operation of public swimming pools based upon the International Swimming Pool and Spa Code. The purpose of this regulation is to ensure that the public is protected and standards are in place for regarding safety features and water quality standards are followed. In order to ensure these standards are complied with, Texas law requires public pool operators obtain training and certifications such as the National Recreation and Parks Association Aquatic Facility Operator, or the Pool and Hot Tub Association Certified Pool Operator. However, the individuals doing inspections of commercial pools are not required by state law to receive any such training. I believe it is common sense that if we're going to require public swim pool operators to receive this training, the same standard should be in place for those who inspect their work. I will note that it was the trade association for the individuals who conduct these inspections who brought me this bill. They believe that providing training for inspectors is critical to protecting public health and safety. The committee substitute is a legislative council draft that makes conforming changes but does not change the effect of the bill as introduced. Thank you for your time. I'd be glad to answer any questions, and I do have a witness here if you have any more nuanced questions.
Questions, members? Representative Alverson.
Thank you, Madam Chair. Thank you, Representative Romero. So who does the inspecting? Is that are those state
City
offices?
inspectors.
Oh, so city inspectors. Okay, so, all right. I was just wondering, like, who does this? Because I hadn't really ever thought about this issue before.
Yeah, and the gentleman can ask if there's any further inspections that are required maybe at the initial construction phase. Some of the pools are larger pools. You'll notice in the bills it mentions lagoons. Some of these are like surf parks and so on. So there may be additional inspectors.
What if it's in an unincorporated area outside of a city? Is there an inspection at that point or just kind of?
You could ask the witness that question. They could tell you.
Okay, thank you.
From the association.
All righty, we'll reserve your right to close.
Thank you.
The chair calls Ben Strubnicki. And I hope I pronounced your last name correctly.
Stobnicki, yes, ma'am.
Stobnicki, okay. And I show you are representing the Texas Environmental Health Association and yourself, and you're for the bill. Is that correct?
That's correct, yes, ma'am.
Okay, please begin.
Yes, ma'am. Good morning, Madam Chair and members of the committee. Thank you so much for having me here today. I'm here, my name is Ben Stobnicki, and I'm testifying on behalf of myself as well as the Texas Environmental Health Association. TEHA, or Texas Environmental Health Association, is a trade association for environmental health professionals such as registered sanitarians and code enforcement officers. Many of our members work excuse me, for local government entities on public health matters related to food safety, wastewater systems, as well as swimming pools and spas. Texas law establishes health and safety requirements for construction, operation, for public swimming pools, and that's in conjunction with the International Swimming Pool and Spa Code. And so public swimming pools would include facilities or activities like apartment complexes, hotels, motels. It could be a homeowner association, could be a college or university that has a pool, or even a high school, as well as maybe a youth camp. All of those have public swimming pools. This bill, House Bill 2424, which we're in support of, would not apply to private swimming pools at a person's home. In order to ensure health and safety standards are complied with, Texas law does require public pool operators to obtain training and certification from the National Recreation and Park Association, the AFO course, or the Pool and Hot Tub Alliance, this certified pool operator course. Additionally, public swimming pools and spas are subject to inspection by local or state regulators to ensure compliance. However, the individuals that are doing the inspections are not required to have any special training in operation or in code compliance, as are the pool operators currently. House Bill 2424 would put the training and education requirement on those inspectors, so they would have at least the same minimum training that the operators do. I will note that many jurisdictions have voluntarily adopted this training standard for their pool inspectors, and we believe it is common sense policy to require the inspector to receive the training. The cost to obtain the training is about $350 and would give a 5-year certification for folks that have taken that course. It takes around 16 hours to actually do the course training. You can do that course training online, or you can take that in in-person training offered throughout the state. Madam Chair, thank you again for hearing my concerns about taking care of and protecting public swimming pools. I would be happy to take any questions you might have.
Questions, members? Representative Alverson.
Thank you, Madam Chair. Mr. Stubnicki, I appreciate you being here today. I was wondering if you could answer some of the questions I was asking Representative Romero. So I understand in the city or inside incorporated area, there's an inspector that would do this inspection. What happens in unincorporated areas or parts of Texas where there is no city?
Normally, that's handled by the state. The state actually handles those inspections. And right now, the state handles those by complaint. And in new build or new constructions in the unincorporated areas, those are typically going to be handled by permit by the state if there is going to be such a requirement. But typically, a lot of the unincorporated areas currently aren't being inspected unless there is a complaint.
And are these all pools or just public pools are we talking about?
These are public pools I'm talking about.
Okay, so if I'm building a pool in my backyard, this doesn't affect me?
This bill does not, no, sir.
Okay, so this would be like a neighborhood pool or a
Correct.
subdivision, whatever. Obviously, I have a lot of those in my district. So
Right.
that's why I'm
Yes,
asking.
sir.
Okay, thank you so much.
You're very welcome.
Other questions, members? All righty, thank you.
You bet. Madam Chair, thank you, committee.
Is there anyone else wishing to testify on, for, or against House Bill 2424? The chair recognizes Representative Romero to close.
Thank you, Madam Chair. Thank you for the questions, Chairman Oliverson. I mean, I think the point of this bill is to make sure that those people that are coming out to inspect are prepared. The technology that goes into just chlorination itself today, it changes every year, it seems like. And we want to make sure that an inspector that comes out knows what he's looking at and doesn't threaten to shut down a pool. And then they bring out somebody that is trained and that person says, no, they were wrong. You're fine. So thank you, members. If you have any questions, otherwise, with that, I close.
All right, thank you. The committee substitute is withdrawn, and if there's no objection, House Bill 2424 will be left pending. The chair hears no objection. House Bill 2424 is left pending without objection. The chair lays out House Bill 5058 and recognizes Representative Kane to explain the bill.
Morning, Chairman Click, members of the committee. I've got I think my bill is 14 words, okay? So I'm trying to keep them short and easy. So House Bill 5058, straightforward bill with a clear purpose to ensure that the Oral Health Improvement Program, or OHIP, dental director would be a Texas licensed dentist. It's really that simple. Despite what OHIP's critical work, there's no current statutory requirement for dental director to be a Texas licensed dentist. So this bill would address that oversight, ensuring that the effective and efficient leadership within the program continues. So, in conclusion, see, we skipped a few paragraphs. My staff's probably happy with me. By requiring a Texas licensed dentist as the dental director, we can ensure that OHIP continues to serve our communities properly with the proper oversight. And therefore, I ask you to support this bill.
Questions, members? Representative Price?
Thank you, Chairman Kane, for bringing the bill. My recollection is that this language was intended to be included in a sunset bill back in like 2015 or 17 by Senator Nelson, and
Very good. Yes, sir. I understand it was an accident.
and it just was left out at the end. So thank you for bringing this back. Appreciate it.
Representative Smith?
I don't know, Chairman Kane, I don't understand this bill. Can you please explain it in a little
Would
bit
you like,
more
would you like me to go slower?
Yeah, a little slower,
Speed?
please.
Okay.
Yeah, absolutely. Thank you.
So by aligning the OHIP dental director position with the
Oh, I got it.
Medicaid
Okay, I got
dental
it.
director.
Okay, I'm sorry, yeah.
Thanks, sir.
Other questions, members? Okay, we do have a resource witness available if anyone needs them. All righty. I'm not showing that you've got anybody registered to testify. Is there anyone else wishing to testify on, for, or against House Bill 5058? Chair recognizes Representative Kane to close.
Thank you, members. It's a great bill. I close.
If there's no objection, House Bill 5058 will be left pending. The chair hears no objection. House Bill 5058 is left pending without objection.
He was on his way 3 minutes ago.
Stand at ease for a minute. Got one more. chair lays out House Bill 3770 and recognizes Representative Busey to explain the bill. I show that you've got a substitute.
Yes.
The chair offers a complete committee substitute.
Thank you, Madam Chair and members, for allowing me the privilege to lay out the committee substitute for House Bill 3770. 3770 seeks to modernize our continuing education tracking systems for the state healthcare licensees. Many licensing agencies haven't been afforded the opportunity to modernize their continuing education tracking systems, and as such, currently employ outdated and opaque legacy operations. This makes it difficult for licensees to tell how many hours they need and in what subjects. Moreover, internal agency staff are often required to pause other important initiatives during license renewal periods to focus on continuing education reporting and compliance, leading to confusion among licensees and agencies as unwieldy and inefficient legacy systems cause all stakeholders to incur losses in time and productivity. And with 1,000 people moving to Texas daily, many of whom are licensed healthcare professionals, already strained legacy systems shoulder a burden that grows heavier and heavier with each passing day. After conversations with stakeholders, we intend to move forward with a committee substitute that would address the following issues. The committee substitute makes several changes from the filed version. First, it specifies the bill does not apply to crematory services, funeral directing, and embalming. The original draft inadvertently included these, but we wanted to focus on what most would typically consider to be healthcare licensing agencies. Secondly, it specifies a continuing education tracking system may not require expenditure by a licensing entity to avoid the fiscal note. And finally, there's an additional transition provision toward the end of the substitute, providing a grandfather clause allowing any licensing entity with an existing continuing education tracking system agreement in place to retain that pre-existing agreement. I want to thank you for hearing this bill. I know we have a few witnesses to talk about this modernization bill, and I request our right to close.
All righty. We'll begin our public testimony. Chair calls Justin Mann. I show you registered as Justin Mann, and you're representing CE Broker and yourself, is that correct?
Yes, that's correct.
And you're for the bill?
Yes.
Okay, please begin.
All right. Good morning, Madam Chair, committee members. My name is Justin Mann. I'm the Chief Operating Officer at CE Broker. I'm here representing myself and CE Broker in support of House Bill 3770, the Continuing Education Modernization Act. In my role, I've led implementations of solutions that modernize continuing educations for over 10 years. My team and I have onboarded over 150 state regulatory board clients, including several statewide and department-wide implementations. I represent one of the many companies that can provide this service for Texas agencies, and to this date, we've never charged a dime to a state government nor lost a state client. The results of these implementations have been astounding. The state of Florida passed legislation 20 years ago modernizing their continuing education system, and they've saved an estimated $500,000 a year through reduced enforcement and auditing costs attributed to this. Next door in Louisiana, the State Medical Board has reduced its auditing and enforcement costs by 75% with a similar system. And here in Texas, the Optometry Board claims that its implementation, quote, brought all stakeholders together in one platform, increased operational efficiencies, and immediately reduced the workload for staff. It's often thought that any solution would be prohibitively expensive or ineffective. Fortunately, that's simply not the case, and I respectfully recommend that Texas assist the ever-growing licensee population and its state employees by adding a no-cost continuing education management platform. We'd be happy to participate in any required state procurement process that is fair and transparent. In closing, without a modern continuing education compliance system, licensees often struggle to understand renewal requirements, find courses that are truly approved, or respond to audits. Regulators often struggle with a wave of audits each renewal season and the corresponding mountain of mailed-in paperwork. A modern continuing education system takes paper off the table and improves digital government services and government transparency for all stakeholders, licensees and regulators alike, through web apps and mobile apps that are configurable to meet the state's exact and unique continuing education requirements. Thank you so much for giving me the opportunity to speak. It's a great honor, and I'm proud as always to serve the state of Texas.
Questions, members? Representative Collier?
Thank you, Madam Chair. Mr. Mann, it says that you are a CE broker. Is that a company or is that?
It's a company, yes.
It's called CE, Continuing Education Broker?
Exactly.
And you're out of Florida?
Yes.
All right. Do you have a presence in Texas at all?
We serve the Optometry Board. They have an existing contract with us. But we don't, I think we have a few employees here. Our Director of External Affairs also hails from Texas.
And so the work that you do is mostly through the software program or something?
Yeah, so we provide the foundation or the structure behind continuing education programs, continuing education management programs, I should say. We're not a content provider. We work in over 26 states now.
Okay, and so the program that you have would allow for healthcare practitioners or anyone who wants to verify that they've complied with the continuing education requirements, they can do that through your software? It's just a check?
Exactly. So they can log in, see what's already been reported on their behalf by education providers. They can self-report if there's any gaps or anything missing. They can see exactly based on who they are, if they're initial licensure, if they have some sort of like military status. They can see the exact requirements that are catered to their unique needs, and they can see how well the activities they've completed match up with those.
And they can't do that right now, currently through their own board?
It's really a patchwork. So certain boards have some degree of modernization or electronic systems. Sometimes it's just essentially a digital Dropbox they can put things into. Who knows if they're compliant or not, or what's in that. In a lot of instances, it's still paper-based.
And is your service mainly for the boards, or is it for the public?
It's for the boards and the licensed practitioners, really equally. The boards get an easy kind of view into their continuing education records. So when it's audit season, I can just look into the CE Broker account first. I don't necessarily need to deal with everybody, okay, it's time to mail me all your documentation or send me like, huge lists of email attachments. And then the licensed professional gets the clarity that they need and the comfort knowing that, hey, in this system, I needed 40 hours, I've got 40 hours, I'm good to go.
And so this would be a cost that the state would have to pay, or the vendor. You're a vendor, right?
Yes, our company would be a potential vendor. I can say that in our experience, we have over 150 state regulatory board clients. We don't charge any money for the service. Other companies that provide similar services might, but historically, we do not charge anything to the state.
How do you get paid then?
Yeah. So our model is that there are optional subscriptions that licensed professionals may purchase. Our service becomes really attractive if you are licensed in multiple professions, which a good percentage of licensees are these days. And so you can pay for just a really inexpensive kind of annual plan that helps you stay on top of multiple requirement sets. For the majority of licensed professionals, and there are 4 million that are now tracked by CE Broker, they don't have to pay anything at all. They can access their account, see what they've already had posted for them. They can post anything they'd like. All of that is free.
Again, how do you get your money?
The optional subscriptions. So there are some licensed professionals who decide, hey, we really like working with CE Broker. I've got license here, multiple places. And then they can subscribe to services that help them just kind of like dive in and see exactly, okay, well, what course can I take that counts for multiple places? Or, how am I doing with Michigan, Florida, South Carolina, all the different licenses that I have. So we've got services that can really help them with that, all the way up to kind of like a concierge plan that a lot of physicians like, where we kind of have more of a personalized touch and we'll help them, like report everything, and they can just email us all their documentation. We'll make sure it gets into their account if needed.
Okay, so the basic plan is just tracking my hours.
Yep.
Make sure that I complied with the state's requirement.
Mm-hmm.
And in each area that the state requires me to have time in or whatever.
Right.
And the premium plan is upgraded for various other services that they can combine.
Exactly, and generally you're going to be into a premium plan or interested in one if you've got complex requirements, multiple states, that kind of thing. But most professionals are on a free plan. It's always been like that, and we're fine with it. We love providing that service.
Okay, thank you.
Yeah, hope that helps.
It does.
Other questions, members? Alrighty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 3770? Chair recognizes Representative Busey to close.
Thank you, Madam Chair. This is one more step in modernization, working with the IT caucus. Got this bill and trying to find ways to help modernize and move the state forward.
Can I have a question?
Representative Collier?
Yes. Representative Busey, do you know of any providers or businesses that do the same type of services as CE Broker in
Yes.
Texas?
I actually have a list of eligible, people that would be eligible if we pass this.
Are they in Texas?
Are they here, or they could be here if this passed and they wanted to apply for this position?
They could be here.
Yeah, they're all over, but I'm saying they could provide this service if Texas passed this bill.
Okay, I just wanted to know if we had any Texas companies that were ready.
I'd have to find out if some of these are specific Texas, but I have a list of about 7 or 8 right here that do this type of service.
Okay, I'll
I can
give it
also
to you.
get you more of that information.
All right, thanks.
Other questions? Representative Jones?
Representative Busey, I'm just trying to understand. As a lawyer, I can go to the State Bar website and I can track my CLE, right? Is there not that same thing?
It's just a patchwork done by subgroup across through the HHSC agency, but each group reports differently. Some have modernized, some haven't. They could do this on their own, but it hasn't been done. Some groups say they want legislative direction to get this done. So we're just trying to make it a streamlined process where anyone could see their continuing education in a database like this.
Because like if the medical board had it, and I don't know if they do or they don't, at least it's consistent. It just seems to me that if there are a bunch of different companies from wherever doing it, then I don't know. Do you know if you can go to some medical website and see like the Texas Medical Board and see what your CLE is?
I think it depends on.
I'm sorry, not CLE, CME.
Sure. I think it depends on your different licenses, and it's done in a patchwork, and this is trying to make that more unique. Probably more like what you're experiencing in the legal profession.
Maybe the State Bar does that. It just seems like it's a no-brainer. But
I agree.
okay, well, not the bill, but like.
No. I agree that it should be streamlined like that.
Okay, all right, thank you.
Absolutely.
Other questions, members?
Thank you, Madam Chair.
Thank you. The committee substitute is withdrawn. If there's no objection, House Bill 3770 will be left pending. The chair hears no objection. House Bill 3770 is left pending. Without objection, the chair lays out House Bill 2635 and recognizes Representative Moody to explain the bill.
Good morning. How's everybody doing? Had an alarm at 3:20 this morning to catch my flight from El Paso. That's not the worst news, though, that I have for you. They don't have pecan coffee in the Capitol Grill anymore, and I'm not sure who we can talk to about that, but it is a matter of my public health that I'm able to have pecan coffee. Okay, now I know. This is something called Bluebonnet coffee, and I'm sure it's fine, but I can't vouch for it yet. Sorry. That's what happens when I don't have enough sleep. Madam Chair, thank you. I appreciate y'all hearing this bill, House Bill 2635. Many of us work in industries, and Representative Jones has talked about our work in the legal arena. We work in industries where we're answerable to a third-party entity outside of our workplace, like a state board. We want to see people in charge of those governing bodies who understand the work we do and the realities we face. It's hard to see anything less as fair. So House Bill 2635 is about providing that representation for advanced practice registered nurses. As you probably know, APRNs are masters or doctorally trained nurses with advanced clinical training and a unique scope of practice relative to many other nurses. They're also growing, with numbers that have doubled in the last decade. Meanwhile, the composition of the Board of Nursing has been static for the last 2 decades. This bill brings the board in line with the nurses it governs by doubling the number of APRNs on it from 1 to 2 and adding an additional public member. It also ensures APRNs act as expert reviewers in investigations and in complaints involving an APRN standard of care, which promotes both the highest standards of care for APRNs and ensures that they're fairly treated during the process. It's a very simple bill, but one that's overdue for the professionals in this growing field. It is, and I know it's not in front of you now, there is a companion bill that has been voted out of the Senate, 31-0, and I know that doesn't mean anything to all of us all the time, but 31-0 and 9-0 out of committee. So that's on its way by Senator LaMantia.
Questions, members? righty.
Thank you.
We'll reserve your right to close and begin public testimony. The chair calls Cindy Weston. Up next will be Amanda Shafton. I show you registered as Cindy Weston, and you're representing the Texas Nurse Practitioners, the APRN Alliance, and yourself, and you're for the bill. Is that correct?
Yes, thank you, Madam Chair and distinguished members of the committee. I'm Cindy Weston, and I'm testing in support of House Bill 2635 on behalf of the Texas Nurse Practitioners, Texas APRN Alliance, and myself. I'm pleased to tell you why this bill is important to pass. This bill will do two things. It will add an APRN representative to the Texas Board of Nursing, and it will clarify language about the disciplinary process of APRNs, creating fairness and justice in a disciplinary process while still supporting patient safety in the state of Texas. I've been a registered nurse licensee in Texas for going on 34 years and an advanced practice registered nurse for 28. Graduate of UT System Schools, starting with UTMB in Galveston, UT Health Science Center in Houston, and San Antonio, and a postmaster's F&P certificate from Texas Tech. Over the past years, you have seen the APRN role grow exponentially in the state of Texas. The last time an APRN was added to the Board of Nursing was in 1999. At that time, there were only 7,500 APRNs in Texas, and today there are over 44,000 in Texas. So with 460% growth in this role, it's appropriate to add an APRN representative to the Board of Nursing. And the Board of Nursing is the best entity to regulate the profession of nursing. This aligns with national standards. So thank you for the support.
Questions, members? Representative Alverson.
Thank you, Madam Chair. One quick question, and that is, how does the disciplinary process work right now for an APRN?
So
Let's say there's a complaint about medical practice, right? So they prescribed the wrong drug, they, did something wrong during the physical exam or whatever. Who investigates that?
Yeah, so a complaint is filed with the Board of Nursing, and they have a complaint process where they bring on an investigator to look at the details of the case. The APRN.
Who is the investigator?
The Board of Nursing uses a variety of investigators right now.
What are their qualifications is what I'm asking.
That's exactly why House Bill 2635 is so important, because the language is not specific in the way the statute exists right now. This would clarify that it's a peer review process of an APRN with a similar role of practice. So it's a clear process.
I guess what I'm asking is, what are the qualifications of the people who are currently doing the review is what I'm asking. Are they physicians? Are they nurses? Who's doing the review?
It is investigators that are hired by the Texas Board of Nursing. It could be a registered nurse. It could be a physician. It could be an individual that's brought on by the Board of Nursing. And House Bill 2635 will clarify that language.
Okay. Madam Chair, do we have the nursing board here?
Let me see.
I do not see them.
Okay, that's okay. I'll ask them questions. Thank you.
Other questions, members? Alrighty, thank you. Chair calls Amanda Shafton. I show you registered as Amanda Shafton, and you're representing the APRN Alliance and yourself, and you're for the bill. Is that correct?
That is correct. Thank you. Good morning, everybody. Thank you for allowing me time to speak with all of you today. My name is Amanda McPherson Shafton. I'm a certified nurse midwife. I practice high-risk obstetrical services here in Austin. I have a master's of science in nursing with a specialization in midwifery, as well as a doctor of nursing practice from Johns Hopkins University. Certified nurse midwives like myself provide well-person, gynecological, prenatal, delivery, and postpartum care here in Texas and across the U.S. I am representing today the consortium of Texas Certified Nurse Midwives, as well as the APRN Alliance, and I'm here to testify in support of this House Bill 2635. This bill, which will add an advanced practice registered nurse to the Texas Board of Nursing, is needed to adequately reflect the growth of the nursing profession in Texas and to bring the Texas Board of Nursing in line with the national standard of other state nursing boards. Adding an additional APRN to the Texas Board of Nursing will strengthen the board and uphold the highest standards of clinical safety. There are approximately 44,000 APRNs practicing in Texas, as you just heard. We are nurse practitioners, we are clinical nurse specialists, certified registered nurse anesthetists, and certified nurse midwives. This number does represent a 462% growth in the APRN field since 1999, which was the last time the composition of the Texas Board of Nursing was updated. This bill ensures APRN peer review for complaints against APRNs involving issues of clinical standard of care. APRNs work in a variety of settings across Texas, providing life-sustaining and life-saving care. While only approximately 15 complaints involving APRN clinical care issues are brought to the Texas Board of Nursing each year, each of these concerns need to be reviewed by an expert to ensure the continued safety of Texas patients. An APRN peer is the best person to review these cases. However, currently that is not required. Anyone undergoing a peer review process would expect a true peer to play a role in their case. I appreciate your support of this common sense bill to increase APRN representation on the Board of Nursing and ensure fair processes for myself and my APRN colleagues, while also promoting safe practice and quality care for Texas patients. Thank you.
Questions, members? All righty, thank you. Is there anyone else wishing to testify on, for, or against House Bill 2635? The chair recognizes Representative Moody to close.
Thank you all so much. And just, and Dr. Oliverson, I sent you this note. According to the background I've got, Section 301.457B of the Nursing Practice Act only provides that each complaint against a nurse that requires a determination of nursing competency shall be reviewed by a board member, consultant, or employee with a nursing background the board considers sufficient. And so there's no explicit requirement for an APRN peer review or definition of what might qualify as sufficient nursing background for purposes of an APRN case. So that's part of the clarifying portions of this bill. I am way out of my depth, but that is what smarter people have told me is the answer.
Right. Other questions, members? All righty, thank you.
Thank you, Madam Chair.
If there's no objection, House Bill 2635 will be left pending. The chair hears no objection. House Bill 2635 is left pending without objection. The chair lays out House Bill 2233 and recognizes Representative Spiller to explain the bill.
Thank you, Madam Chair Click, Vice Chair Campos, members. I appreciate you allowing me the opportunity to lay out House Bill 2233. This bill requires 6 hours of mental health training for first responders as part of their existing program. The bill was brought to me by a constituent who had who related to this concern on a personal and a family level. And the intent behind the legislation is to ensure that we provide our first responders with the necessary resources to effectively respond to traumatic events that they may encounter relating to mental health. So there's a committee substitute that includes input from various stakeholders who encounter these types of situations.
We don't have your substitute.
Okay, we'll try to get that to you. But we've dealt with several stakeholders who encounter those situations who are already in the process of putting similar programs in place. So in working with stakeholders, we're able to modify the language to reflect that the current curriculum that's already in place be administered by Texas A&M Engineering Extension Service. So in addition, the committee substitute would require Texas A&M Engineering Extension Service to collaborate also with other agencies, the Texas Commission on Fire Protection, the Texas Commission on Law Enforcement, and the Department of State Health Services. So hopefully that will address any kind of concerns raised. We're happy to work with any other parties interested parties to modify the language if and to the extent necessary, address any unintended consequences. And with that, Madam Chair, subject to any questions you may have of me, I thank you for your time and respectfully reserve the right to close.
Members, any questions for Representative Spiller? Okay, I'm not showing anybody registered to testify on your bill. Is there anyone wishing to testify on, for, or against House Bill 2233? Chair recognizes Representative Spiller to close.
Got one.
He's not listed.
Yeah, he's on a do not testify. So, yeah, so call him up and ask him if he wants to be shown against or for.
Okay, could you come up and state your name?
Joshua Norman.
And were you wanting to show you're testifying on, for, or against the bill?
Not testifying, I just want to say that we're for.
You are now, though.
Yes, that the second registration is correct. I fumble fingered it this morning.
If you could have him say who he is. who
Okay,
he's
if you could
representing in his
say your
position.
name, who you're representing, and your position on the issue.
Joshua Norman, Harris County Deputies Organization, Fraternal Order of Police, number 39, and we're for.
Okay.
And you're giving me
And you're giving me permission to change your registration to for the bill?
Yes, removing the against.
And removing the against. Okay, thank you.
Thank you.
And, okay, alrighty, thank you.
Thank you, Chair.
Chair recognizes Representative Spiller to close.
Thank you, and I appreciate any of your favorable consideration. I close.
All right. If there's no objection, House Bill 2233 will be left pending. The chair hears no objection. House Bill 2233 is left pending without objection. The chair lays out House Bill 3903 and recognizes Representative Ortega to explain the bill. I understand you have a committee substitute.
That is correct.
The chair offers a complete committee substitute.
Thank you, Madam Chair Click and Vice Chair Campos and members of the committee. Thank you for the opportunity to lay out the committee substitute, House Bill 3903. Current law requires 2 certificates of medical examination before someone is committed. One of the 2 must be prepared by psychiatrists. Because there is no legal definition for the term psychiatrist, the term is construed as defined by the medical community, a physician whose practice is focused on psychiatry. Until recently, this approach naturally encompassed psychiatric residents pursuing board certification in psychiatry because they are, by definition, a physician whose practice is focused on psychiatry. An appellate court invalidated this approach, pointing to the absence of a definition and a fast-approaching legislative session. Texas is underserved when it comes to psychiatrists. In average, there is 1 psychiatrist for every 12,500 state constituents. And in places like Tarrant County, Comal County, and El Paso County, the number is even lower than that of the state average. This means that without psychiatric residents to help prepare certificates of medical examinations, mental health consumers will have to wait longer to receive emergency psychiatric care. HB 3903 addresses the problem by enacting the definition found in the administrative code and construing the term consistent with the medical community. I have an attorney from the county attorney's office here to testify, and I'm available to answer any questions that you may have. And if there are no questions, I reserve the right to close.
Any questions?
Questions? All right, thank you.
Thank you. The chair calls Michael Gomez. Good morning. Thank you for being here. I show that you're registered as Michael Gomez, and you're with the El Paso County Attorney's Office. Is that correct?
That's correct.
And you're for the bill?
Correct.
You may proceed.
Thank you.
You're welcome.
My name is Michael Gomez. I'm an El Paso County attorney. I'm here representing El Paso County Attorney John Bernal in support of House Bill 3903. Thank you, committee, for hearing this bill, and thank you to Representative Ortega for her work on it. Back in El Paso, I oversee the mental health litigation unit for the county attorney's office. I am involved in all the involuntary civil commitment proceedings, which are often taken as a last resort to help individuals that are experiencing a significant mental health crisis. One proceeding that stands out in my mind is that of an individual that was brought out to our local county hospital because he was delusional and he wanted to cut his chest open because he thought he had inside an E-ray. Fortunately, I'll refer to this individual as John Doe, but fortunately, John Doe was properly evaluated and treated by 2 psychiatric residents that ultimately saved his life by providing the necessary medical examinations to go forth on a commitment. Now, regrettably, this type of fast-paced psychiatric intervention is no longer allowed if it only involves psychiatric residents. You see, in Texas, to commit someone, the law requires that there be 2 certificates of medical examinations prepared by 2 different physicians, one of whom must be a psychiatrist. Surprisingly, though, the law does not define what a psychiatrist is. And so in John Doe's case, the 2 psychiatric residents were able to intervene because up until recently, the term psychiatrist was construed as defined by the medical community, and that is a physician whose practice is focused in psychiatry, and a definition which naturally encompasses psychiatric residents. It's worth noting that that same definition, or that there is a similar definition in the Texas Administrative Code. But in any event, a recent court ruling out of El Paso invalidated this approach by pointing to the absence of a definition and then calling out on you, specifically the legislature, to make any necessary changes as you saw fit to fix the problem. As you can imagine, the court's decision greatly diminished the number of psychiatrists available in Texas. As it stands now, Texas is below the national average when it comes to psychiatrists. In Texas, there's about 1 psychiatrist for every 12,500 people. But in places like El Paso and Comal counties, the number is far lower, with about 1 psychiatrist for every 19,000 people. That is about 50% less than the national average. Without this bill, people like John Doe would no longer have access to quick emergency psychiatric care that can be provided by psychiatric residents. This bill takes a crucial step in eliminating an unnecessary obstacle and closing gaps in mental health services by providing a workable definition that mirrors that found in the Texas Administrative Code. For all those reasons, we humbly ask for your support in House Bill 3903, and I'm available to answer any questions.
Thank you. Are there any questions? Thank you for your oh, sorry. Representative Jones.
All this bill does is define psychiatrists to be a postgraduate psychiatry resident who's being supervised so that they can help with the commitment process. Is that accurate?
It adds that to the definition, but there's 2 other definitions as well. Just I believe board certification, just a standard what you would expect from a physician that's board certified in psychiatry, but it also encompasses psychiatric residents that are pursuing board certification.
Right, so that's what I mean. It said eligible for board certification, so it doesn't require that you be board certified, and that I guess you're trying to get a board certification. So that would get, so like just a resident who's a psychiatry resident who's not applying for board certification, would that kind of resident be allowed?
No, Representative Jones. I think it's physicians that are board certified or board eligible. And then when it comes to psychiatric residents, it's limited to those that are pursuing board certification and are being supervised by either a board certified or board eligible physician.
Okay, thank you.
Thank you for your testimony.
Thank you.
The chair calls Roberto Cutcher Diaz. Good morning. I show that you're registered as Roberto Cutcher Diaz, and you're for the bill, and you're here on behalf of yourself. Is that correct?
Yes, ma'am.
Okay, you may continue.
Good morning, members of the committee. My name is Roberto Cutcher Diaz. I'm a medical doctor working as a second-year psychiatry resident for Texas Tech University Health Sciences Center of El Paso. I'm here to present my testimony in favor of House Bill 3903. As a medical graduate, my academic preparation included theoretical and clinically applicable education in all fields of medicine, including psychiatry. As a psychiatry resident, my education has involved both extensive formal education as well as being directly involved in the diagnosis, prevention, and treatment of hundreds of patients with psychiatric conditions in different settings. This includes psychiatric facilities, outpatient clinics, and consultation liaison services at our medical hospital. I should also mention I also have a master's degree in public health. In El Paso, much like the rest of Texas and the United States, there are many issues related to limited access for mental health treatment. This can have a domino effect, which can affect other aspects of medical care. I'll start with what I've seen happen at our medical hospital. Many patients with acute psychiatric illness end up at the emergency department, which can occur for multiple reasons. However, once a safety concern is recognized, they are placed under an involuntary hold until appropriate care can be coordinated. This causes a strain on the emergency department, as there are times when these patients refuse treatment and may become aggressive or even violent due to their mental illness. This problem compounds when the psychiatric hospitals, which have limited bed availability, can't accept them, and as a result, the patients remain in the emergency department, actively deteriorating under the stress of acute mental illness and lack of definitive psychiatric care. This can further limit the community's healthcare access as the emergency department reaches capacity and critical care for other medical issues, such as strokes, heart attacks, are diverted, resulting in delayed care, which can have severe implications. This is a similar picture to what occurred when I submitted an application for a patient at the emergency department in order to provide much-needed psychiatric treatment on an involuntary basis. By this time, I had already testified in the final hearing of dozens of patients and filed close to 100 certificates of medical examination. And whenever a final hearing for involuntary treatment is held, it takes in-depth knowledge about the patient's current situation, their past history, exhausting all other options, having an active treatment plan ready, and being able to present sound reasoning for the commitment from a biopsychosocial perspective. All of this with my attending physician's approval. The purpose of residency is to practice medicine at the highest level that our profession allows, using every possible resource available to help our patients, all while under the supervision of an attending physician. When a patient goes to a hospital, it is the resident who handles the patient's needs directly with the help of the support staff available. The medical system is designed so that residents manage patients and treatment is not delayed. If patients who arrived to the emergency department needed to wait until an attending physician saw them, the wait times would become extreme and the system would likely collapse, especially in underserved areas. Similar to a surgeon's necessity for an operating room, the legal process, including the mental health court, is an essential resource within psychiatry. I've been fortunate enough to be part of a program that allowed me to participate directly in the medical legal process as part of my training. It would be hard to imagine finishing residency without this critical experience. I hope with the passing of this bill, future residents are able to do the same, helping reduce the delay of care, providing assistance to an already strained healthcare system, and creating more attending psychiatrists who are competent in the medical legal process, all with the ultimate goal of helping our patients. Thank you so much for the opportunity to bring this matter to your attention.
Questions, members? Thank you.
Thank you.
Chair calls Afshan Khan. I show you're representing Texas 400 and yourself, and you're for the bill, is that correct?
Yes, I am. Good morning, Madam Chair and Vice Chair and committee members. I'm Afshan Khan. I'm an adult and child psychiatrist practicing in Austin. I've got training from 3 different countries, India, UK, and United States. And I'm here to testify on behalf of Texas 400 and myself in support of House Bill 3903. I'm bringing a different angle than what they have mentioned. There are several reasons why the term psychiatrist should be reserved for physicians. First, psychiatrists deal with complex medical issues that require specialized medical knowledge and training. Mental illness are medical conditions that require diagnosis, treatment by a medical doctor. Psychiatrists have the necessary medical expertise to diagnose and treat mental illness, including prescribing medications, which is a skill that only medical doctors are legally allowed to perform. Second, the title of psychiatrist is a protected title in many countries, meaning the required medical training and obtain the necessary qualification can use the title. This protection of the title is in place to ensure that patients receive high-quality care from qualified professionals. Finally, using the term psychiatrist to describe non-medical professionals could be confusing and potentially harmful for patients. Patients who seek care from non-medical professionals who use the term psychiatrist could receive treatment that is not based on sound medical principles, potentially putting this mental health at risk. In conclusion, the term psychiatrist should be reserved for physicians who have completed the medical training and qualification to diagnose and treat patients. This protects patients by ensuring they receive high-quality care from qualified professionals and avoid confusion or potential harm from non-medical professionals using this protected title. And I see this on a daily basis in my private practice, where I'm really retreating people who kind of use wrong terminologies like psychiatrists and do not have the detailed and profound medical knowledge, and do a lot of polypharmacy to my patients. So it's been a lot of work for me to re-educate patients about who they're getting care from and what kind of care, especially with more complex cases. Thank you for
Questions, members? Thank you. Chair calls Pamela Lopez. Show you registered as Pamela Lopez, and you're representing yourself, and you're for the bill, is that correct?
Correct.
All right, please begin.
So good morning, and thank you for allowing me to speak. My name is Dr. Pamela Lopez, and I also work for Texas Tech Health Sciences Center in El Paso, Texas. Unlike Dr. Kutcher, I am not a resident physician. I'm actually one of his supervisors. I am an attending physician. But I want to make sure that I clarify that I'm not speaking on behalf of the institution I work for, that I come here as a private citizen. Nonetheless, I do believe that my work at Texas Tech University helps me to be able to speak from a very unique and important perspective relative to the subject matter. I am board certified both in general psychiatry and consultation liaison psychiatry by the American Board of Psychiatry and Neurology. I completed both my residency and fellowship here in Austin, Texas. In fact, some of it was just a few blocks away from here. While I absolutely loved living here and I wanted to stay here, I decided to move back to El Paso, which is my hometown, specifically because I wanted to practice academic medicine. And I wanted to work in a particularly underserved community, and El Paso is certainly underserved in mental health. To tell you how underserved El Paso is, at the time of my move, which was approximately 5 years ago, I was the only board-certified consultation liaison psychiatrist in the entire city. I tell you this because the shortage of psychiatrists in El Paso and most of Texas, for that matter, is incredibly problematic. A way to combat such shortage is to expand the education of future psychiatrists, which is what I am involved in every single day. Not only am I an attending physician at Texas Tech, one of the specific roles I serve in is as program director for one of the 2 psychiatric residency programs there in El Paso. So in essence, I am in charge of supervising resident physicians, but more so making sure that they are meeting all the requirements in order for them to graduate as competent psychiatric providers. So the amount of training these resident physicians are expected to complete is very extensive. They are held to very high standards, and there is oversight in their training at all times by numerous different modalities, all of which are overseen by the Accreditation Council for Graduate Medical Education, the ACGME. Not only are resident physicians fully capable of participating in the legal proceedings of involuntary commitment due to mental illness, as a training director, I know firsthand that they must know and participate in such before graduating. As a psychiatrist, it is equally important to know mental health law, including knowing how to file and testify on behalf of patients when there is an imminent risk due to psychiatric illness. It's equally important as it is to treat mental illness itself. Not allowing resident psychiatric physicians to do so would be equivalent to not allowing a surgery resident perform a surgery until they graduated and no longer had any oversight. So I would like for you to please consider formally including resident physicians, completing their psychiatric residency training to be able to be a part of this very important part of their training, but more importantly, such an important part of mental health treatment overall in Texas. Thank you.
Representative Collier.
Thank you. Seems like El Paso came strong today. You're El Paso strong, very good. Dr. Lopez.
Yes.
I want to ask you about I don't practice medicine, I practice law, so I don't know, I'm not as familiar with the process. So I go to medical school, and then after I graduate medical school, I'm a doctor.
Correct.
And then I go into a specialty, which is psychiatry.
Correct.
So we just heard from Dr. Diaz, and you said there's only 2 psychiatric residency slots in your area?
There are 2 residency programs.
Oh, 2
So
programs.
one of the programs, I think each class is 8, 10? 8?
8.
Where I practice, it's an extension of Texas Tech, but it's on the other part of town. It was developed because we still need a lot of psychiatrists. And so that takes 4 residents per year.
So there's like 12 for the whole area?
For each year. So psychiatric residency training for just to become a general psychiatrist is a 4-year residency program.
Okay. I want to say that last bit that you gave us, that analogy was spot on. It helped me really understand what you're talking about, because in law, we can get our 3L barcode, and it gives us the opportunity to practice in court under the direct supervision of a lawyer. So same thing. So thank you so much.
Absolutely.
Very important.
Absolutely.
Other questions, members? Alrighty, thank you.
Thank you.
Is there anyone else wishing to testify on, for, or against House Bill 3903? Chair recognizes Representative Ortega to close.
Thank you. I close and ask that you please report House Bill 3903 favorably out of committee. And if there are no other questions, then I'm done.
Alrighty. The committee substitute is withdrawn. If there is no objection, House Bill 3903 will be left pending. The chair hears no objection. House Bill 3903 is left pending without objection. The chair lays out House Bill 4286 and recognizes Representative Jones to explain the bill.
Thank you, Chair Click, Vice Chair Campos, and my fellow colleagues of the Public Health Committee. The Occupation Code stipulates that any appointment of the chairman of the Funeral Commission must change between public and non-public members every 3 years. This mandate changes every 3 years, severely limits the potential pool of candidates for the chair of the funeral commissions, and results in a mandated loss of critical institutional knowledge. We should be able to select the most qualified candidate to serve at the role of chair. House Bill 4286 is a simple bill that will repeal the required 3-year change and require the governor to pick the most qualified candidate. This practice is not new. There are over 25 boards and commissions that have adopted the same proactive approach, such as the Texas Alcohol Beverage Commission, Animal Health Commission, and the Texas Medical Board. When we select Texans to lead on various boards and commissions, we should be picking our very best. It's time that we do the same for our funeral commission. Members, if anyone have any questions, I'll be more than happy to answer them at this time. And with that, I reserve my right to close.
Question, members? Okay, and I've not shown anyone registered to testify. Is there anyone wishing to testify on, for, or against House Bill 4286? Chair recognizes Representative Jones to close.
Thank you so much. I close.
If there's no objection, House Bill 4286 will be left pending. The chair hears no objection. House Bill 4286 is left pending without objection. The chair lays out House Bill 5117 and recognizes Representative Morales to explain the bill.
Mr. Chair, if you can give me a few minutes, I'm waiting for my folder, my layout folder. He's supposed to be on his way.
Stand at ease for a moment.
Want me to do it?
Okay, we're going to go ahead and do Representative Cortez's bill. Chair lays out House Bill 2882 and recognizes Representative Campos. Okay, we're back in order. The chair lays out House Bill 2882 and recognizes Representative Campos to explain the bill for Representative Cortez.
Thank you, Madam Chair and members, for allowing me to lay out House Bill 2882. Despite their expensive training and education, physician assistants in Texas are currently restricted by business codes that have little to do with their medical background. While physician assistants must be supervised by physicians and their medical practices, this oversight has been extended to the business side of the healthcare service industry. As a result, physician assistants are prohibited from serving as officers or general partners for a corporation or professional association, even if there are created a partnership with the physician. This restriction of opportunity is a disservice to the impressive qualifications and training of physician assistants. HB 2882 is designed to release physician assistants from these limitations. Under this bill, physician assistants will be allowed to serve as governing persons within their respective business and for professional associations. This will give them the opportunity to use their considerable knowledge, skills, and expertise to contribute to the growth and success of their practice and associations, enabling them to enhance the overall quality of healthcare in the state of Texas. We look forward to working with the committee officers, and I've got any questions and reserve the right to close.
Okay, great. We will, members, do you have a question for Representative Campos? Okay. We will begin our public testimony. The chair calls Kathy McLaughlin. Dr. McLaughlin, I show you're testifying on behalf of Texas 400 and yourself. Is that correct?
Yes, ma'am.
And you are against the bill.
Yes, ma'am. Thank you, Madam Chair and Vice Chair Campos, for the opportunity to testify. I'm Dr. Kathy McLaughlin. I represent Texas 400 and myself, and I respectfully oppose this bill. This bill eliminates 3 sections of the Business Organizations Code, which would allow physician assistants to become managing partners in a medical practice. Currently, that managing role is held by a physician or the physicians who own the practice. Because management tasks and management decisions in a medical practice often pertain to the practice of medicine itself, the managing role should remain a physician-only task. For example, what drugs should be kept and stocked in the clinic, which dosages should be bought and given, which medical devices and equipment should be used, what treatment protocols should be in place, and what personnel can perform those treatments. These decisions all pertain to the practice of medicine. However, those tasks are not specifically delineated in the current business code, and there are bound to be some management decisions that fall in a gray area. This bill would create additional ambiguity and potentially cause conflict between the physician managing partner and the physician assistant. In any functioning medical practice, there is expected collaboration between the physicians, the physician assistants, and any other clinicians that work in that practice together. That collaboration can still continue without any current changes to the existing code. Thank you.
Questions, members? Alrighty, thank you.
Thank you.
Chair calls Catherine McDonald. Next on deck will be Valerie Cavazos. I show you registered as Catherine McDonald. You're representing yourself and you're for the bill, is that correct?
Yes, ma'am.
Please begin.
Good afternoon, committee members. My name is Catherine McDonald, and I'm here today to voice my support for House Bill 2882 on behalf of myself. I have been a PA since 2010, working in Louisiana until I moved to the great state of Texas for more opportunity in 2019. As you are all likely aware, Texas is home to the most Fortune 500 companies in the U.S. It is a powerhouse for small businesses and haven to entrepreneurs who wish to get their start due to the favorable tax laws that this legislature has worked hard to create. 99% of all businesses in the state are small businesses, and they employ about 45% of Texas's workforce. PA professionals provide a service similar to any other small business. Unfortunately, due to the fact that my colleagues and I chose to serve the citizens of Texas as PAs, we have to either be a silent partner, essentially giving our name, title, and resources to a company while relying on administrators, some of whom may not even have medical backgrounds, to make decisions affecting the health of the business. Or we can remain employees and retain the ability to manage the day-to-day operations for the benefit of our employers. I am deeply invested in seeing this legislation modernized, as I have taken the time to secure an MBA. Medical professionals that have taken the extra step to build competency in the business of medicine and have entrepreneurial spirits are penalized by the rules and regulations placed on our profession. This has the unfortunate consequence of not encouraging PAs to settle in Texas, and some have made the hard decision to leave the state to pursue business opportunities in more favorable climates. To stifle professionals who have the vision and drive to want to do more for the community mostly robs the communities of the services and additional access to care. Ultimately, in a free capitalistic market, healthcare business ownership should not be withheld from citizens strictly because of antiquated regulations. In closing, I'd like to iterate that our request with this bill is not for additional scope of practice, nor are we asking to modify the minority share of the business, simply to be able to own and manage our business in conjunction with our physician colleagues. The state of Texas is currently short of medical professionals that can provide quality care to our citizens. We shouldn't sideline a group of professionals with a skill set that can help to mitigate this problem, because some of these PA professionals want to experience the American dream, what is now the Texan dream. I thank you for your time and attention and kindly ask for your support for House Bill 2882.
Questions, members? All right, thank you. Chair calls Valerie Cavazos. Up next will be Alicia Fowler. I show you registered as Valerie Cavazos.
I have.
And you are representing the Texas Academy of Physicians Assistants and yourself, and you're for the bill.
Correct.
Please begin.
Thank you. Chair Click, Vice Chair Campos, and esteemed members of the Public Health Committee, My name is Valerie Cavazos, founder of the Burnout Project and Orthopedic Specialty PA. I am testifying in support of House Bill 2882 on behalf of the Texas Academy of Physician Assistants and myself. This bill is essential for allowing PAs to participate in business operations and management of medical practices where they hold a minority stake ownership. Many PAs invest their time, effort, and financial resources into minority stake ownership medical practices. However, despite having the trust of their physician co-owners, they are currently restricted from serving as officers or partners in managing the business. This includes, for example, choosing an electronic medical record, hiring medical staff, taking out business loans, and making structural improvements to the practice building. As financial stakeholders in a company, a PA should be able to take an active role in business administration, which is separate from the clinical role. As you can see from the map we have provided in the folders, PAs play a vital role in Texas healthcare provisions, being co-owners in 109 practice locations with constituents in some of your very own districts. Out of the 109 co-owned practices, Representative Tinderholt has 4, Representative Smith has 3, Representative Johnson has 1, and Vice Chair Campos has 1 entity. Our hope in passing this bill is to allow for more physician PA partnerships to increase job opportunities and expand regional business investments. Passing House Bill 2882 could act as a catalyst for more PAs to co-own. Improved business expansion initiatives, which this bill represents, provides opportunities for growth, development, and innovation for rural and underserved areas of Texas. Currently, PA co-owners are expected to share liability, but are not legally able to take an active role in any business decisions. Accepting liability without a vote is a legal burden that a PA co-owner should not have to passively accept, and really is a fundamental legal right any stakeholder should have. Passing House Bill 2882 would allow for business partners to have fair representation in co-owned responsibilities, establishing more logistical and efficient business decisions without legal ramifications. This ultimately benefits the community, the economy, and provides for increased patient resources. This change will not interfere with patient care, will not alter ownership percentages, or increase a PA's scope of practice. PAs are simply asking to have a seat at the table to make business practice decisions that they already are financially invested in. I urge you to support House Bill 2882. By empowering PAs in business co-owned practice management, they can better serve our communities and contribute to a more successful healthcare system overall. Thank you for your consideration.
Questions, members? Thank you. Representative Jones.
Does this mean that physician's assistants would employ physicians?
So it depends on what the relationship is, but potentially
is that a
yes. Potentially yes, as contractors within a business.
Thank you.
Mm-hmm.
Other questions, members? All right, thank you.
Thank you.
Chair calls Alicia Fowler. Next on deck will be Eva Montes. I show you registered as Alicia Fowler, and you're representing yourself and you're for the bill. Is that correct?
That's correct.
Okay, please begin.
Thank you, Chair Click and Co-Chair Campos and members for the opportunity to testify for House Bill 2882. My name is Alicia Fowler. I'm from Van Alstyne, Texas, and I'm testifying on behalf of myself as a family practice clinician in PA clinical practice for 18 years. I currently practice in rural family medicine in Bonham, Texas. I'm a constituent of Representative Smith's, and I'm grateful that I'm able to practice in rural medicine similar to where I grew up. According to the Texas Hospital Association, 21 rural hospitals in Texas have closed in the last decade, and this is more than any other state. Other rural hospitals have started eliminating key service lines In 2022, a report from Kaufman Hall found that 26% of Texas rural hospitals were found to be at risk of closure. This was up from 16% in 2020. The clinic where I currently work is owned by a rural critical access hospital. We are also in a designated healthcare provider shortage area. And at one time, our hospital and the clinic where I work was at risk for closure, which would have left a significant number of patients without access to care. I am also the only provider that provides care for the indigent care of the county. I am one of 2 females that provide care for a population of greater than 10,000. The majority of any of our specialty groups that we refer to is 30 miles away. So oftentimes I am kind of the first line for preventing a bad medical outcome. We've had, in the 12 years that I've been at Bonham, we've had 6 physicians in family medicine and various other specialties come through, none of which have lasted more than a year and sometimes as short as a month, where I'm one of the constants. So closing the clinic would have worsened access to healthcare in an area that's already plagued by a shortage of providers. So at the time of the potential closure, the physician that I work with, who I've worked with over 12 years, and I had entertained the idea of opening a co-owned clinic. And that partnership was actually encouraged by my physician and is still encouraged, but we work in separate cities. He has a full-time practice there. He supervises other clinics, and he wouldn't be available for the day-to-day management decisions for a clinic. So ultimately we decided that we couldn't sustain that type of business venture given the current restrictions of this law containing against PAs making any business or management decisions for a clinic, and it doesn't change the ownership percentages. So if you could imagine in that situation where we had closed, then also imagine how many more potential PA and physicians could partner in business to ensure the control of the medical practice stays local and the access to care for patients stays local with the passage of this bill. So I urge you to support House Bill 2882 and allow PAs to have a voice in physician and PA co-owned medical practices. Thank you, and I appreciate your time.
Questions, members? Okay, thank you. Eva Montes. I show you representing the Texas Academy of PAs and yourself.
That is correct.
You're for the bill.
I am. Thank you, Chair Click, Co-Chair Campos, and members for the opportunity to testify in support of House Bill 2882. A special thanks to Representative Cortez for being a champion for this bill. My name is Eva Montes, and I am testifying on behalf of the Texas Academy of PAs and myself. As past president of the Texas Academy of PAs and a PA in clinical practice for 20 years, this legislation is incredibly important to me as it affects the employees I work with and the patients I serve here in Austin. I first want to address some of the testimony and clear up some matters. We have an occupations code that determines our scope, and we have an administrative code that determines ownership and ownership decisions. The PA would not be hiring their supervising physician. That is against the administrative code. So in those situations, there would not be a situation where a PA would be hiring a physician because we cannot hire our own supervising physician. So in that regard, when the occupation code lays out our scope, different code, at the practice, at the clinical practice, we have a collaboration agreement that takes care of drug samples, it takes care of anything to do with clinical medicine. This is a different code, it's the administrative code. So I just wanted to clear that up. No change in percentage, no change in scope, no change in how the physician practices medicine, and we will not be hiring our physicians. The last 13 years of my 20-year career, I've had the fortune of working with the same physician. Not sure that admitting to the committee this information is well served, but that is my longest relationship so far. When you work with somebody in tandem for that long, you build a mutual trust and mutual respect. The physician is the leader of the clinical team. There is no question about that. On the business side of things, that dynamic can be more fluid. There are many occasions when the physician wants to hand over the lead on the business details. However, this current law effectively renders me a silent partner in the business, and it is a physician and PA co-owned. In the early stages of COVID, word spread about a practice in the Panhandle in Representative Ford Price's district that was forced to close. The physician and the physician PA co-owned practice died, and the PA could not move forward with any business decisions. In the midst of a healthcare crisis, those patients were left without their healthcare team. This is particularly concerning, given the data we heard regarding physician shortages and hospital closures in rural areas where PAs play an integral part in delivering healthcare access. Keeping the staff safe and patients alive was priority number one during COVID. Pivoting to telemedicine meant less patient encounters and therefore less revenue in the practice. The practice faced the threat of having to lay off employees and or cut healthcare benefits to save money. Knowing that laying off a medical assistant that's a single mother would devastate her family, or cutting healthcare benefits during a healthcare crisis was unconscionable. We weren't sure if the business would get a PPP loan, and nevertheless, all the providers in the practice took a pay cut, so we could avoid layoffs and avoid changing any of the benefits. The option did not exist for me to apply for a small business loan or a PPP loan in my name. The current regulation as written prohibits me from doing so. I'd be forced to take out a personal loan, which puts my family's personal assets at risk. One of the protections afforded to owners of certain business entities is protection of personal assets. PA co-owners are not afforded this protection under the current law. I don't worry about the responsibilities I have to the staff 49% of the time. I worry 100% of the time because they are like my family. PAs that are co-owners in medical practices deserve protection from liability and the right to make decisions regarding the way their businesses are managed. I urge you to enthusiastically vote yes on HB 2882 to allow PAs to have an active role in the management of the business they co-own with physicians.
Questions, members? Representative Jones.
I'm looking at section 22.0561B of the Business Organizations Code, and so I'm confused. It says that it's going to repeal that section, which says the physician assistant may not be an officer of the corporation. But when you're, which I actually think conflicts with section C, which is still there, that says a physician assistant may not contract with or employ a physician to be a supervising physician of the physician assistant or any physician in the corporation. So I'm confused because if you're running the business and you are directly employing who works for that business, including physicians. So I don't understand. To me, they come part and parcel.
For sure.
So as a person who's a manager of a corporation, how is it that you don't have any say of what physicians work for that corporation?
Because it's co-owned and the physicians are the lead in that business. I'm a minority owner. It doesn't mean I can't have any say-so in the business aspect, but in hiring aspects, because of C, I will not be involved in hiring any physician. And PAs will not be involved because we, by the law, are delegated authority, and we have to have supervising physicians. And it is against the law. It's against the code. So that's not a situation that I worry that any PA is going to have a problem with. It's not about a power play. It's not about being apart from the physician. The whole idea and the whole impetus of PAs was by a physician, not only for healthcare access, and now in this modern time when PAs have been here for 50 years, we have partnerships, and we like those partnerships. We enjoy those partnerships, and that can include business, but it does not carry over, and it will not carry over to hiring your supervising physician.
But I just don't understand, as a person who gets to make decisions on how the business is run, how you don't do that. Like you have a vote. And I think that with the law as it stands now, there's a clear line of demarcation, because if you're not on the board, then you can't hire or employ or supervise physicians. And if you take that away, then you necessarily are doing that, even if the physician doesn't listen to you. And then how do you control for the physician's assistant who does want to run the doctors? Because that's going to happen. That's going to happen.
So in any board, even if you're an officer on a board, because I'm on the Texas Academy board, I've served on many boards, you can recuse yourself. You can be asked to recuse yourself. and again, if it's in conflict, right, with that, if your physician, who is your partner, who is the majority owner, says to you, hey, in this meeting, we're discussing the employment. Now, and here's what we're doing, we're discussing employment of physician. They would be within their realm and right to say, you're going to recuse yourself in this vote.
Question, so can you be a majority as a physician? I'm just
Absolutely not. No, this is not changing any percentage of ownership. And if there are two physician owners, the PA has to be the minority owner of those.
What if there's a physician and a PA?
It's 51-49. It can never be more than the majority of the physician, ever. Before 2011, it was that way. I mean, after 2011, it was not. And those practices still
I'm
exist.
really struggling with physician and physicians.
I appreciate you.
Because those things conflict with each other, but thank you.
Yep, no problem.
Dr. Alverson?
Thank you, Madam Chair. Ethan, I appreciate your testimony. I think we need to be, and I think you tried to do it, but I want to clarify a little bit of what you tried to clarify, which is that I think a physician assistant cannot practice in the state of Texas without a supervising physician. Is that right? How many supervising physicians is a PA required to have?
A PA can have
No, how many are they required to have?
at least one.
One, right. So what you say is true, but to be clear, if you're in a group practice, you could have a physician who's supervising you. You could have other physicians that are not supervising you that you absolutely could employ. Correct?
You could, but again, in the statute, with collaborating practice agreements, I have another physician in the practice that I work. He
So
is
do
not my
you- so
supervising
does-
physician, but he is the emergency supervising physician for me in case something happens. So in those cases, because we know that happens sometimes, again, technically in the letter of the law, could you do it? Sure. But again, with the statute, the way it is, it's a slippery slope, and with nothing else changing, certainly as a Texas Academy of PAs, we'd advise against any PA being involved in that.
So you're also repealing the section in section 152.0551 that prohibits a physician assistant from being the general partner in the management of the practice. So, I mean, yes, I get that the statute says that you can't employ your supervising physician, but if this law passes, there's no prohibition that you can't employ physicians. You just can't employ the physician that's supervising you, but you could employ physicians all day long, as long as it's not the one that's supervising you.
If your physician partner was okay with that, I suppose you could. The whole benefit of having the partnership and the fear in 2011 of corporate takeover of medicine is why this law was made. And on the House floor, an amendment was made to have PAs not have any voice. But before 2011, there were physician PA co-owners that were 50-50. But the whole idea, PAs are not corporations, right? PAs are partners with their physicians. So the whole idea of the 51-49 is that is a majority, right? And so it would be hard pressed to say a PA would walk in the room and say, I do or don't want to hire this physician, or I do want to hire this physician, and now it'd be hard pressed for me to imagine that scenario. But again, in the letter of the law, yes, if it is not a supervising physician, could you do it? Sure, but then if you're at the same practice and your physician's not available, in our collaborative practice agreement that we have to have on file, a lot of times those physicians are listed as that as well.
Well, it seems to me that you would have to do it. If you were the general partner in a medical practice that was looking to hire an associate physician, a non-partner, a non-shareholder physician to come into the practice, and you're the general partner as the PA or one of the general partners, you would have to employ that physician. You would have to execute that agreement. There's nothing in here that says that you would have to recuse yourself from that hiring decision.
But it doesn't say you can't also. It doesn't say you can't recuse yourself. And again,
Okay, so typically when we put exclusions and things like that, we write that into the statute, but I don't see any evidence in this bill that you've done that. So, I mean, I guess what I'm saying is, you're saying that wouldn't happen. I'm saying that absolutely could happen, and it would happen under any circumstance where you're a general partner and you're bringing on a new hiree who happens to be a physician. Now, whether that person is then expressly prohibited from supervising you, I don't know. But the reality is this is a very good workaround to the system that is. I mean, you absolutely could create the scenario that you say that you're attempting to avoid.
And I think in statute, when you put things in statute, I think sometimes when, just like at a clinical practice, when a physician and PA are making decisions about things, sometimes that does tie your hands from things that are logical and make sense. I understand your concern. I understand everyone's concern about the issue of hiring physicians and benefiting off of that, or it just for whatever reason. I mean, that's, sort of monetary gain and not having any semblance of what the team leader is supposed to be in clinical medicine, but as well as this statute that says 51-49%.
Do business decisions in medical practices sometimes bleed over into clinical decision-making in terms of directions that clinical practices want to go?
I would say in terms of direct patient care and how you're going to treat a patient, that collaborative practice agreement is in the occupations code. So in the administrative code and business,
I know where it is, but what I'm saying is, practically speaking, when the general partners get together and they're making decisions about the group, part of those decisions is how they're going to manage certain things, or new technologies that maybe they want to invest in, or new drugs, or different ideas that they have for how they want to practice or what direction they want the practice to go. So what I'm saying to you is that there definitely are situations in a medical practice, in any medical practice, where the general partners will make clinical management decisions that affect all the other practitioners in that practice.
sure, EMR, at the current practice that I have, there are things like electronic medical record, which one are you going to pick? There's many to pick. So things like that, when you're in direct patient care, that's something that can be done. Anything to do with drugs or the use of that, again, is going to be in the collaborative practice agreement, which is different.
But now you're a general partner, so you have a vote and a decision about how, and that affects all of your employees, some of whom may be physicians as well. So you do essentially have oversight and authority over them.
But you don't have the majority
in terms of their clinical management.
But you don't have the majority.
Well, okay, depending on how many people there are, right. You could have a significant percentage of interest and ownership, though.
Sure.
Okay, all right, so I appreciate it.
Thank you.
Other questions, members? Representative Jones?
I've looked at the three sections that you want to carve out, the 22.0561B, 152.0551B, and 301.012A2. And I think what Dr. Oliverson was talking about is it says that you can manage. It's pulling that one part out. And then pulling that one part out absolutely creates ambiguity about what you can do. And if you do that with with those specific sections, and it literally, whether you intend to or not, allows a way to go over, under, around, whatever, that you get to make decisions about physicians. And so I don't know if that was an intended consequence of what you're trying to do, but I think the law needs to be clear about what people can and cannot do. And I think that scope of practice needs to be clear about what you can and cannot do. Otherwise, you're just asking for a lot of problems. And the carve-outs that you want, whether you intend to or not, at least in my interpretation of the three specific sections that you want repealed, allows physicians' assistants to practice medicine. Even though you're saying we only have a minority stake. And so I just think it's problematic for me.
I appreciate that. So practicing medicine, I think, would be direct patient care. That collaborative practice in our scope is very clear. That is very clear in the occupations code about practicing medicine. NPAs don't practice medicine. We are delegated that authority. Yeah, and so it's not there.
Yeah, but you get to hire the people or fire the people who practice medicine. And in a scenario where you may have a physician who's just absentee, like he's literally letting you run the practice, right? Maybe it's fruitful or whatever, where you literally would be making those decisions. So I don't want to go back and forth with you.
I appreciate your concern, and I appreciate the safety of the community, and I appreciate that. And again, respecting the physician-PA relationship, which I do, and again, in our training is inherent to say that, to say this is this is your lane. And I speak to my physician every day, and, previous testimony would have you think that, PAs are kind of running around there, not collaborating, not speaking with their physicians, but, and not having any of that exchange or any of that guidance, because they are the guidance, to how we do things, so.
I'm just letting you know my concerns.
I appreciate it.
Right? I'm just letting you know my concerns, and the specific carve-outs allows physicians' assistants to make decisions about the employment of doctors and what happens in that medical practice. So, I don't want to go, all I got is a vote.
Yeah.
Right? So, thank you.
Thank you.
Other questions, members? Alrighty, thank you.
Thank you so much.
Is there anyone else wishing to testify on, for, or against House Bill 2882? Chair recognizes Representative Campos to close.
Thank you, committee members, and I close on behalf of Representative Cortez.
If there's no objection, House Bill 2882 will be left pending. The chair hears no objection. House Bill 2882 is left pending without objection. The chair lays out House Bill 5117 and recognizes Representative Morales to explain the bill.
Thank you, Madam Chair Click, Vice Chair Campos, and the members for giving me the opportunity to lay out 5117. What this bill does is simple. It's going to be extremely impactful for our region, especially West Texas and El Paso out there and throughout the state. During the COVID-19 pandemic, DSHS announced its temporary personnel staffing waiver, which authorized local medical directors of licensed EMS providers to permit the deployment of qualified but not formally certified personnel to staff licensed EMS vehicles. This bill does not authorize non-licensed EMS drivers to perform necessary medical services, but rather simply allows them to drive the vehicle only. There's been a sharp decline in EMS training program enrollment, and this bill will help ensure the stability of the EMS workforce by making the ability of licensed EMS providers to recruit and utilize qualified but not formally certified personnel for non-medical duty to be permanent status. The Senate companion, which is Senate Bill 1588 by Senator Blanco, passed unanimously out of the Senate and would be great for all Texans, especially in our rural areas. I will happily take any questions. But if there's none, Madam Chair, I respectfully reserve the right to close. And I believe that we have the Texas Ambulance Association, Rachel Herrickson from El Paso and Brett Coughlin from Brenham that can address any issues that you may have.
We'll reserve your right to close and go to public testimony. Chair calls Rachel Herrickson. Up next will be Brett Coughlin. Good morning. I hope I pronounced your last name correctly.
You did an awesome job.
Great. I show you representing Life Ambulance and Texas Ambulance Association and yourself.
Yes, ma'am.
And you're for the bill.
Absolutely.
Thank you. Please
Thank
begin.
you. Good morning, Chairman and the Public Health Committee. I want to thank you for allowing me to testify today. My name is Rachel Herrickson. I'm president of Life Ambulance in El Paso, and I am legislative chair for the Texas Ambulance Association. And we, of course, support House Bill 5117. This bill helps to ensure adequate staffing for licensed EMS vehicles. The state of Texas, once again, had an extremely sharp decline in EMS personnel during COVID. Emergency medical technicians left pre-hospital care due to numerous reasons. One was to avoid occupational exposure, long working hours, for lucrative government contracting, and because of non-competitive wages due to low reimbursements that providers receive from state and federal funding. The pandemic's severe impact on EMS workforce was recognized immediately through the Department of Health Services. And DSHS requested a grant from the governor's office and was granted that grant, or that waiver. And that waiver allowed for EMS staffing to be addressed. And part of that was allowing, once again, drivers for qualified agencies. And this waiver went away November the 25th, and since then, the statewide waiver is no longer in effect, and that's why this bill is extremely important. And it helps to actually streamline the variance process, which is crucial for communities that are short of EMTs. We would like to thank the County of El Paso and Representative Morales for sponsoring this bill. Do you have any questions that I could address?
Questions, members? All righty, thank you.
Awesome, thank you.
Chair calls Brett Coughlin. Up on deck next will be Elisa Tamayo. And I show you as representing the Texas Ambulance Association, and you're for the bill. Is that correct?
Yes, ma'am.
All righty, please begin.
Honorable Chairman Click and board members, committee members, I appreciate y'all allowing me the opportunity to testify. My name is Brett Coughlin. I'm with Austin County EMS. I'm the Vice President of Texas Ambulance Association. House Bill 5117 is very much needed right now because by having the variance allowed by the state, we could take somebody that's not certified and make them a driver, and then we can send them into ECA classes and on into EMT classes to get them into the EMS world. Right now, there's a shortage in staff. I also teach at TEACS, which has an EMS program, fire programs and all of that. And we're finishing a paramedic program right now that has 6 people in it. So we're trying to get more people involved in EMS, and this variance will allow the state to do that. We had a variance until November 25th when the governor's variance has ended. That has helped us survive. But COVID has taken a lot of people out of EMS because they don't want to take a chance of getting sick and going home to their families. I've been in EMS for 37 years, and it's nothing like that's going to worry me now because I've been here too long. So I appreciate the time y'all given me to testify. Any questions?
Questions, members? All right, thank you.
Thank you.
Elisa Tamayo. And I show that you...
Yes, Elisa Tamayo, Governmental Affairs Manager for El Paso County for the bill.
Okay, thank you.
Thank you, Chairwoman Click, Vice Chairwoman Campos, and committee members. And thank you, Representative Morales, for bringing up this bill that is critical for El Paso County and for other counties across Texas. I don't want to repeat everything that was said. I think he did a great job laying out the bill. But we just want to reiterate that we have not been able to fully recover from the COVID-19 pandemic. Our workforce shortages are still there, and so we're fully supportive of this bill on behalf of El Paso County. Thank you.
Questions, members?
Yes.
No, go ahead.
Thank you. Is there anyone else wishing to testify on, for, or against House Bill 5117? Chair recognizes Representative Morales to close.
So, Madam Chair and members, you know, the current status of EMS shortage shows that only 43% of certified personnel are working in EMS today. And it's even worse out there in West Texas because of the federal agency involved in addressing some of those federal issues with the migrant surge. So you're having EMS folks that are certified being pulled from that to work for NGOs, to work for private contractors, or to work in administration also. And so we're seeing less and less. This bill will hopefully address that issue, especially out there in West Texas and in El Paso. And I'd ask that it be provided your favorable vote and passed on to the full House. Unless you have any questions, I rest.
Thank you. If there's no objection, House Bill 5117 will be left pending. The chair hears no objection. House Bill 5117 is left pending without objection.
I believe that's all I have. May I have excuse? Thank you, Madam Chair.
The chair lays out House Bill 2322 and recognizes Representative Johnson on behalf of Representative Zwiener to lay out the bill.
Yes, Chairwoman, and may I proceed from the dais?
Yes.
Thank you very much. On behalf of Representative Zwiener,
House Bill 2322 seeks to correct the information healthcare facilities are required to give sexual assault survivors. HHSC typically puts forth several legislative initiatives. They're intended to be small cleanup statutory changes to provide operational clarity and efficiency. This bill addresses one of those issues. Current language on a form provided to sex assault survivors suggests that if a sexual assault survivor chooses to make a report to law enforcement must first authorize the forensic examination, which is not the case. This language may have the unintended consequence of discouraging sexual assault survivors from obtaining a forensic exam or a provider delaying care if they believe law enforcement must authorize this first. This bill would remove the language that states if you make a report, law enforcement must first authorize the examination, making this clarification. Believe there are potentially a resource witness available to answer questions and reserve the right to close.
Questions, members? Okay, is there anyone wishing to testify on, for, or against House Bill 2322? Chair recognizes Representative Johnson to close.
I close. Thank you.
Didn't lay out the committees. Okay.
Just say.
House Bill 2322 is left pending without objection. And this one. Okay, the chair lays out House Bill 2072 and recognizes Representative Chabot.
Thank you, Chair. Members, I'm here to lay out House Bill 2072, which expands Senate Bill 292, which from a prior session to include nonprofit organizations to list of qualified entities that can apply for a grant to establish a program to reduce recidivism, arrest, and incarceration of individuals with mental illness. Currently, only county-based community collaboratives are eligible to receive grants to establish these programs. This bill intends to expand mental health services by increasing the number of organizations that can apply for these funds through HHSC. Additional funds have been appropriated in the House budget for this grant. Existing county programs will not be impacted or at risk of losing funding as a result of this bill. The committee substitute amends Section 531.09935 of the Government Code to conform it with the changes made in the original bill. At this time, I'm happy to answer any questions. If not, I reserve the right to close. I'm sorry.
And lay out the chair offers a complete committee substitute. Any questions for Representative Chabot? We have one. We'll begin our public testimony and reserve your right to close. The chair calls Lee Johnson. I show you as testifying on behalf of the Texas Council of Community Centers, and you're neutral in the bill. Is that correct?
Yes, Madam Chair, that's correct.
Please begin.
Thank you. Thank you very much, Madam Chair. My name is Lee Johnson. I serve as the Chief Executive Officer for the Texas Council of Community Centers. We're the state association that represents the 39 local mental health authorities of Texas. I'm testifying here on House Bill 2072. I've not yet seen the committee substitute, but I'll be requesting that here shortly. The Texas Council supports Representative Chabot's interest in ensuring nonprofit organizations have the opportunity to bring their resources to the table to address gaps in mental health services, including gaps that exist in the intersection of mental health and criminal justice. However, we have serious concerns about the unintended consequences of achieving this goal in a way that diminishes the incentive and opportunity that was created by law in 2017 for local government, the local mental health authorities, the counties, the hospital districts, if there is one, to work together in fulfilling their constitutional and statutory responsibilities for people with mental illness in the justice system. In 2017, the passage of SB 292 with a focus on recidivism, arrest, and incarceration of individuals with mental illness, and the passage of House Bill 13 with broader focus on addressing gaps in mental health services marked the first time that legislation and funding came together to support governmental entities, SB 292 with responsibilities in addressing that justice interface, and other community initiatives with private entities, HB 13, to address locally identified gaps. For our system, this conversation goes back to 2003, when the state faced a substantial budget shortfall. That session, the legislature enacted cuts, biennial cuts of more than $200 million from our system of care. Additionally, legislation enacted in 2003 directed our system to provide more comprehensive services to a narrower population and conduct jail diversion planning that specifically narrowed our services to people with diagnostic categories of bipolar, major depression, and schizophrenia, and children with serious emotional disturbance. In tandem, the narrowing of the target population and the cuts that session resulted in thousands of adults and children losing access to mental health care across the state, which resulted also in increased demand on the criminal justice system. In 2007, the legislature began a series of substantial investments. With the $82 million investment was the first step to create the crisis response system in Texas, and then that set in motion a series of funding initiatives over multiple sessions to respond to the crisis and address the need for ongoing care. The Texas Council supports expanding access to services through both the SB 292 framework and the House Bill 13 framework. Among the investments made by the legislature over the last decade, these two strategies stand out as solid steps to both support local government in fulfilling their constitutional and statutory obligations, and to support the growing interest and willingness of private entities to address mental health gaps, including providing services that divert people from jails. I also note, as Chair Jatan noted, HB1 and SB1 include $15 million in new funds for the HB 13 grant program and $30 million in new funds for the SB 292 grant program. We'll continue to work closely with Representative Jatan and his staff to address our concerns. Thank you for the opportunity to testify. Do my best to answer any questions.
Questions, members? Representative Jones?
Yes, you said you're neutral. You said you're thankful for for trying to fill the gap for nonprofits. But you said you had some serious concerns. Can you give me the specific concerns, please?
Yes, ma'am. The SB 292 framework was designed to facilitate collaboration and coordination between governmental entities with the statutory and constitutional obligation to address the needs of individuals with mental illness in the justice system. This bill proposes to change that framework by adding any nonprofit into that structure. And we're suggesting that the House Bill 13 framework, which already allows any nonprofit to participate, is the better approach. And we're also very supportive of the increased funds that have been identified in the budget. Those last legislative session, the legislature saw fit to streamline the local match requirements that are associated with the SB 292 and House Bill 13 grant programs, but the legislature has not invested additional resources in those programs since they were initially created in 2017. And we're hopeful that those additional resources will do exactly what's proposed here in expanding access to these services and create more grant programs across Texas.
So you are concerned about nonprofits being allowed to be in, or you're not?
I am concerned about nonprofits coming into the framework that was established in SB 292. And nonprofits, I'm suggesting, can already participate in the House Bill 13 grant program in the framework that was established in that construct.
Okay, thank you.
Yes, ma'am.
Other questions, members? Representative Collier?
Yes, Mr. Johnson, I just want to clarify some things. So you said use the HB 13 approach. Right now, I'm just trying to figure out, is there a gap in the needs for this service for the jail-based competency restoration program? Is that being met by local mental health authorities?
Yes, ma'am, there are many gaps in services that exist at the local level.
Okay.
The jail-based competency restoration programs is one example of that. Today, there are 6 of those programs. Some of them are actually funded through the SB 292 initiative, which is established and based on that partnership between the county, between the jails and between the local mental health authorities, those entities with that constitutional and statutory responsibility. And so, yes, there are many gaps. What we would really like to see, and we're hopeful, if the investments that have been proposed in these grant programs that are in the current budget being considered now, if those investments make it over the finish line, we're hopeful that we're going to see other communities be able to come together to fill the gaps that exist in their communities as well.
So if the funding, so right now there's funding for the SB
292.
and the HB 13.
Yes, ma'am.
And so if there's additional funding for HB 13, would we need to have this provision pass in this bill?
I don't believe so.
Okay.
I believe that the framework and the statutory framework that exists today is solid. The real issue is needing additional resources to be invested in these programs so that additional recipients can apply and potentially be awarded those grants. The SB 292, of course, is for governmental entities. And then also the House Bill 13 framework, which is, of course, for any nonprofit that can step up and help fill those gaps.
Okay.
We support both of those structures. Yes, ma'am.
And then that's where I was going with the SB 292 framework is for governmental entities. And it was originally written that to not include nonprofits.
It was initially constructed to be an incentive for local governmental entities
To work together.
Yes, ma'am.
And so have you seen that happen?
Yes, ma'am, I have.
Okay, I believe in Tarrant County, we have that unique system in place where our MHMR, our county, and our jail all work together, and they have an agreement to provide these services. And I guess, you know, one of the goals is to do it in a manner that's fiscally responsible to the taxpayers. And I'm not saying nonprofits wouldn't do that, but they all probably have the same common goal by being, you know, county-oriented as well. So my question about the nonprofits, if you have an agreement like we do in Tarrant County, would that agreement have to be, I guess, removed, eliminated, and then they have to go out for a new contract? Or do you understand the process, or do I need to ask the resource witness?
Well, I think you'll have a resource witness from the agency that can talk about that, probably in a more detailed way than I could. You know, grants are typically on a time cycle. And as I understand it, all of the grants that are out there today are on a time cycle to end August 31st. I suppose that those grants could be extended, but I know you have a resource witness here who could talk about that in more detail. I would say, Representative Collier, from our standpoint, the bigger issue here really is the proposed change to that statutory framework for the SB 292 program, in that adding any nonprofit into that, basically it reduces and potentially impacts the collaboration incentive for those governmental entities at the local level. And that's really the key part to this framework. The House Bill 13 framework that was enacted in 2017 at the same time already creates opportunity for any nonprofit to be involved in these efforts.
And they could do jail-based competency too?
Yes, ma'am. In partnership with the local mental health authority, they could.
In partnership. And is there any type of, not confidentiality, but there may be some things that are disclosed between the county entities or quasi-county entities that may not, I don't know, that may not be relevant to the practice or the work of the nonprofit organization? I'm just trying to figure out if maybe they're sharing information that may not necessarily be relevant. I don't know. I have to ask Mom.
Yeah, that's a bit outside of my scope, but I do know that they collect a lot of information and share that information through their performance contract with the state.
Okay, I'll ask the resource witness the next questions. Thank you.
Other questions, members? Alrighty, thank you.
Thank you very much, Madam Chair. Thank you, members.
Chair calls Sonia Gaines. Good morning.
Good morning.
I show you are the Deputy Executive Commissioner with the Health and Human Services Commission, and you're neutral on the bill, is that correct?
That's correct.
All righty. Representative Collier, I believe, has some questions.
Thank you so much, Ms. Gaines. So good to see you again. So I got some questions I just want to follow up on. For current projects, like in my district, where we use these funds to do jail-based competency restoration, can I be assured that the current project will not be disrupted and that September 1st will see the project continue?
So if this bill passes, the way we propose to operationalize is that there's 15 million per year that House Bill 1 is allowing for additional dollars. Those dollars we will allow nonprofits as well as the community collaboratives to participate. That will require a procurement, a formal procurement. And so we will do that. In terms of the existing, you're asking about existing grantees and initiatives that are going on today. What we propose, and that's the 25 million that currently exists, is that we will continue those grants through an amendment that will continue through 2025. So, it's our intention that the current grantees would not be negatively impacted, and we will maintain the 25 million per year for the existing grantees.
Okay, because I'm looking at the effective date, and it says it takes effect September 1st, 2023. And so then if the grants are about to expire in August, this would not be impacted by that?
So the bill is silent currently on what we must do with the existing grantees. And if it continues that way, we would have the option to continue through an amendment with the current grantees and basically take the 15 million of the new dollars and do a procurement for that.
So then the extension would not include the $15 million?
The extension would not include the $15 million.
Okay.
Some of this is about timing as well.
Sure.
It also, by the time this bill is passed, then we'll have to do a procurement. A procurement takes about 2 years from start to end. When we're working with governmental entities, which the 292 currently allows for, we don't have to do a formal procurement. We do something called a needs capacity assessment. That process takes about half the time. It takes 12 months.
Okay, so you're in your mind, you're thinking that the agency would just do an extension, and would you do it for 2 years or what? Because you said it takes 2 years.
We're gonna do the extension through 2025 for the existing grantees. There's 22 of them.
Okay, and so, because I just want to make sure we don't have a gap in the services, because, I'm assuming that since this program started, these 6 LMHAs that are doing this have put a lot of time and effort into create the program and the relationships that they have in their respective communities. And so it may take a minute to just do the transition, and I want to make sure that we're not missing out, or we're not, dropping the ball on that.
Yeah, again, unless we're instructed differently, the way the bill is constructed currently, it's silent on, it doesn't say that we have to put it all together. The way the bill is constructed currently, it allows nonprofits to, be eligible for a grant. And so the way we were going to construct it, unless we're told otherwise, is to take the 15 million and open that up for the nonprofits to compete for that, as well as the community collaboratives, which also include the local mental health authorities.
So if you're saying that you would take the 15 million, which wouldn't become effective till September 1st of 2023, and are you saying that the 15, I think you did say this, that the 15, I just have to make sure I say it the way, will there be an opportunity for this current project to be expanded through the new funding? And I think you said no.
To allow the current project?
Yeah, if you do a project, and you're saying that then if you're going to extend it, it's not going to have that 15 million.
So understand if we kind of look at this as 2 cohorts.
Okay.
The current grantees, there's 22 of them. They already have about 82 collaboratives, entities that are involved in the collaboratives. We don't want to disrupt that, to your point.
Okay.
And so what we will do is, those are all governmental entities, the way the grant was originally designed. We will continue that funding through 2025 with those grantees. We will create another cohort with this $15 million that was allocated through House Bill 1. And then that will be the allowable dollars that the nonprofits could submit an application for.
And they could overlap in terms of could you get it ready by September 1st of this year?
So the grant process from start to end,
2 years.
when you involve a non-governmental entity, will take 2 years.
So let me ask you this question. I thought I heard you say something like it didn't prevent you from doing a hybrid type of program.
Right. So here's the bottom line. The bottom line is the current grantees, 22 of them, will not be negatively impacted the way we propose to operationalize this currently, unless we are instructed to do something different.
Okay. And so the current grantees, when that $15 million becomes available, they could also apply for that.
If they meet the eligibility qualifications, which they will, because the bill as it's currently written, it's still, what it's doing is allowing the nonprofits to become a part of the eligible entity. It does, and so now it would be a community collaborative, which also includes an LMHA plus a nonprofit.
Okay.
So both of them will be will be eligible with this 15 million.
And you could do even a hybrid, saying like you do this part of the Justice Restoration Program, and then you do this part, LMHA.
And that could be a part of the collaborative. That's something that we're not involved in, but they would come to the table with their application.
Okay, so if you can do any type of program though, right? For this 292, that's a justice-involved program?
Pretty much, yeah. The justice involved, we're trying to prevent people with mental health conditions from going into the judicial system, and, staying away from jail, that sort of thing. There's one particular thing in statute that I do want to, bring to your attention, and that you mentioned jail-based competency restoration.
Right.
There's clear statute language that has to be performed or subcontracted through a local mental health authority. And so that cannot be direct contracted with a nonprofit.
So the jail-based restoration program has to be through an LMHA.
LMHA,
Okay,
along with the outpatient competency restoration. Those two, there's clear language in statute that would prevent a nonprofit from doing that directly. They could do it as a subcontractor.
Okay, what do you mean? Tell me the difference.
Like they could, if the LMHA was the applicant, they could subcontract with a nonprofit.
Okay.
But it always has to go through a local mental health authority.
And based on your reading of this bill, it wouldn't change that. I'm going to ask the bill officer that too, make sure I understand that. Because if they already have something going, I just want to make sure that my county get to do the good work that they're doing.
I would say yes.
Okay, all right. And then, let's see here. Oh, would the local government or the county have a say? I don't know if this is one of the questions that you would put in there in your procurement process. Like, if they're going to partner up with the local governmental entity to provide some type of justice-involved services, would they have input into the applicant's eligibility, quality, or whatever? Is that something that you've done before?
Yeah, so normally in the application instructions, we talk about collaboratives and who should be involved and that sort of thing. And so naturally, if there's a program that has an impact on the county, we would expect that the county has had some input into the design and, the impact of that type of program. A lot of times the applications are also accompanied by letters of support from the various entities. So that shows us, we don't just, have someone list, we usually want to see some evidence of a collaborative, because that's a major part of the actual grant.
Okay, and so, but that's not in your, grant, RFP or whatever?
It will be.
Oh, it will be,
yes.
okay.
The expectation of that collaboration is clearly outlined in the grant application.
And so when you, if it takes 2 years to create the grant program, by the time it's awarded, you expect the awardee to be able to implement the program immediately? Yeah.
Well, I mean, we normally have a negotiation on what is reasonable. As you can well imagine, normally with these types of programs, it requires some lead time to get people hired, to get people trained.
Sure.
So we normally have those conversations.
Okay, all right. Well, I mean, by immediately, meaning like they're ready to take on the project once they are awarded. Because of course, I probably don't have everybody on staff right now because I'm waiting for the award. Right. But you expect them to start their project, and you do not expect any disruptions in services for our local government by implementing this bill. So if somebody's already doing the services and they've got the contract now, you don't anticipate any disruption, and there should be a continuity of the service.
Unless we are instructed otherwise, as I mentioned, the bill is silent on what we must do with current grantees. And so, to your point, to minimize negative impact with current grantees, we would operationalize this by allowing the current grantees, 22 of them, to continue the services as they currently are through 2025. And then we could do another NCA for that group. And then we would still have the 15 million, if that gets approved, that we can allow the nonprofits to participate in.
Okay, thank you. That's it.
Representative Johnson.
What all does the House Bill 13 grants cover?
So that is more general mental health services. So it also does allow for, justice-involved services. And it will, that grant, as it is currently constructed, does allow for nonprofits to participate in. And so the difference between the two is that 292 is specifically geared towards governmental entities, and it's focused on, keeping people out of the jail system. On 13, it's general mental health, and I can tell you we have, we have all sorts of programs, and then we have several nonprofits that are already participating in that. And I will say, even on with Senate Bill 13, we already have some justice impacted type programs as well.
In this language, it talks about a qualified entity, either being a community-based or county-based community collaborative or a nonprofit. Just to clarify and put me at ease, are there additional requirements for how a nonprofit becomes qualified to work with mental health individuals?
Well, it just depends on what it is that they're doing. Like I indicated before, there are certain things that nonprofits cannot do when it comes to the justice involved, like the jail-based competency restoration, outpatient competency restoration. And then depending on what other type of service they're proposing that they're going to do, we make sure that all the credentials are in line, all the qualifications are there for whatever it is that they might say that they want to do.
Can you tell me, just to clarify, because I'm worried about the definition where it just says, hey, if you're a nonprofit, you qualify. Can you just put my mind at ease and tell me, are there other provisions of which you guys are going to look at to say you have to have certain training, certain background, certain?
Yeah.
Okay.
Yes,
That's in
absolutely.
statute for HHS.
So
this would not supersede anything that you are.
Absolutely. It's an exhaustive process. We have a contracts department on both the program side and at our state office. And it's pretty in-depth in terms of looking at making sure, first of all, when the application comes in, and I'm talking about House Bill 13, that they meet all the qualifications. If they don't meet the qualifications, the application is not even considered. And then even with the selection process, same thing.
Thank you very much. Thank you, Chairwoman.
Other questions, members? Ready, thank you.
Welcome.
Is there anyone else wishing to testify on, for, or against House Bill 2072? The chair recognizes Representative Jeton to close.
Thank you, Chair. Thank you for the opportunity to lay out this bill and for the witnesses that came and testified. I think we do have an opportunity to provide more services around the state in terms of reducing the recidivism, arrest, and incarceration of individuals with mental illness. And happy to answer any questions. Otherwise, I close. There's a question.
Yeah.
Representative Collier.
Thank you, Madam Chair. So you heard Ms. Gaines talk about the implementation part. Is it your intent to leave the implementation up to the agency as they just discussed right today?
Absolutely. And what she described is exactly, my intentions for it. It should not be to disrupt any programs that are currently going. And it's just an opportunity for nonprofits to be able to specialize and use those funds for this purpose. And with HB 13, I think it is clear that there's something that allows for nonprofits. It's much bigger, and there's a lot of people in that pool. Having the ability to have more nonprofits fill in that gap where needed is, I think, a good thing around the state.
And then in terms of, I heard Ms. Gaines talk about the jail-based competency restoration program has to be done through the LMHA. Would your bill require LMHAs to work with nonprofits in order for them to have the opportunity to apply for funding or to receive any type of funding? Or could LMHAs continue to do that on their own?
I don't believe it changes the way that LMHAs must interact or perform their duties when it comes to SB 292 implementation or the grants.
Okay, thank you.
Representative Jones.
So when we're talking about jail-based competency, it's hard. It takes forever for it to happen, even when the state facilities are doing it. And so it makes sense to me that nonprofits can't do that because it's just nuanced. So is it your intention with this legislation doesn't change that, right? So they still can't do that.
That's
I'm sorry,
correct.
when I say they, I mean nonprofits still can't do jail-based competency or restoration.
LMHAs are still the ones that have to qualify for that grant to be able to perform those services. And as you mentioned, can subcontract with nonprofits, but at the end of the day, LMHAs are the ones that are able to implement and control a jail-based competency restoration program.
Okay, thank you.
Other questions, members?
With that, I close.
Okay, the committee substitute is withdrawn, and if there's no objection, House Bill 2072 will be left pending. The chair hears no objection. House Bill 2072 is left pending without objection. The chair lays out House Bill 2826 and recognizes Representative Alverson to explain the bill.
Thank you, Madam Chair and committee members. I appreciate the opportunity to discuss House Bill 2826. And I should point out that its identical companion is Senate Bill 1249. Chairwoman Click and committee members, I'm sure you're familiar with the option to register as an organ donor through DPS and Donate Life Texas when applying for a driver's license or ID card. In fact, more than 13 million Texans are currently registered as donors. However, in most cases, waiting for a life-saving organ means waiting until the registered donor passes away, which unfortunately makes organ donation less accessible to folks that need it when you consider the fact that more than 85% of the 100,000 plus people who are on the national transplant waiting list today are waiting for kidney, and another 11% are waiting for liver, neither of which procedure requires somebody passing away in order for the organ to be donated, as we have 2 kidneys and liver transplants are normally done with a fraction of a person's liver, so they were able to live without it. And so that means that 96% of organ donations that are currently needed to save lives could come from a living donor as opposed to a donor who is deceased. And so this bill directs HHSC to establish the Living Organ Donor Education Program in order to raise awareness and educate Texans about the critical need for living donors. The bill specifies that HHSC is to partner with Donate Life America and the National Donate Life Living Donor Registry to develop written and electronic informational materials explaining living organ donation and the process of registering for being a living organ donor. And that is what it does, Madam Chair, and I would be happy to take any questions. Otherwise, I'd like to reserve my right to close.
Questions, members? Representative Jones?
I absolutely always think that you die when you donate your body or organs, which, by the way, don't kill me, but I've donated my body. But, like, what can I give as a living person? I'm just curious.
That's a great question, Representative. So the most common things that are donated as a living donor, the most common organ is a kidney. And since we all have two kidneys and, you know, in most cases, not all cases, both kidneys are functioning sufficiently that if one kidney was lost, the donor, the person donating a kidney, would still have complete function from a renal standpoint to be able to eliminate the toxins and regulate the water and on all the things that the kidneys do. So your God gave you two, but in most cases you only need one to function, which means that it is certainly the case that you have the capacity as a person with two healthy kidneys to save a life of somebody who's on dialysis and is waiting for a kidney transplant. And so that's really what this do. Now, liver is a little more rare, but in the case of a liver transplant, we only transplant a section of a person's liver, so you can donate a portion of your liver without giving up the whole thing. Again, your body, as long as you're healthy, your body has excess capacity in the liver, so you don't actually have to have all of it present. And so it is possible to donate a portion of your liver to save the life of someone else without losing your liver function yourself.
So you're anticipating, it seems like maybe if I'm a family member and I've got the same, and I can't remember what you call it, where you can take my organs or whatever, I would do that. Do you anticipate people will be like, oh, I just want to donate my liver, and then is somebody making money off of it?
Well, there's not really, as far as I know, there's not really money being made other than to cover the cost of the program. I will tell you, in my capacity as insurance chair, I would tell you that organ transplantation surgery is very expensive, but it's life-saving. And I forgot to mention that bone marrow is also another thing that you can donate. It's not a solid organ, but it's another example of a donation that can be made as a person who's alive to save the life of another person that may have leukemia or another condition that requires a bone marrow transplant. So I think the main thing here is that if you had a relative or an immediate family member who was a match for you and you were in need of a kidney transplant, you would probably be made aware of the fact that if you're a match for that person, and if you donated your kidney, your uncle or your child or your relative, your brother or your sister, may be able to not be on dialysis anymore and to have normal kidney function. But if you're a non-related person, so in other words, you're somebody who's registered as an organ donor, you've made that selection on your driver's license, but you didn't, you're not aware that you can actually donate a kidney to someone who's not related to you while you're alive and still maintain completely normal function of your body for yourself. That's something that, not saying that you would have to, but making that available to people to know that while you're alive, you can still save a life. You don't have to wait until, your time on earth is coming to a close to save someone's life. You can save someone's life today by donating a kidney or part of your liver.
Thank you.
Yeah.
Other questions, members? Okay. We will begin public testimony and reserve your right to close. The chair calls Greg Cox. Good morning.
Good morning.
I show you registered as Greg Cox, and you're representing yourself, and you're for the bill, correct?
That's correct. My name is Greg Cox. Many of you probably know the author of the Senate Companion Bill. He is my father-in-law and also my kidney recipient. My journey into living organ donation started when I met my wife 10 years ago here in this building, and her dad at the time was suffering with a genetic autoimmune kidney disease that would eventually require him to get a transplant. And I found out I was a match. It's a long story and there's a lot to be said, but found out I was a match and was happy to do it and did it. And I think I'm here today to talk about this bill because I get really one of two reactions when people learn I gave a kidney to my father-in-law. The first is adoration. You're the best son-in-law in the world. The second is I would never do that. You're insane. That's crazy. I think those two reactions kind of show the need for the bill. Living kidney donation is very common. It's very normal. It's very safe. My experience was I went under. The anesthesia was great. I went under at about 6:30 in the morning. I woke up early afternoon. I was home. I was walking around that night. I was home the next day. I was back at work in about 10 days. And so it's a very viable thing. And in a state with, pushing 30 million people, we've only got 10,000 people that need a kidney. So I think this bill will save lives. So thank you. I'd be happy to answer any questions.
Questions, members? Representative Alverson.
Greg, I just want to thank you for being here today, and I want to thank you for your compassion and your sacrifice and your selflessness, and obviously your father-in-law is beloved by myself and many, many people in this building. And so he's just very, very darn lucky to have a son-in-law like you. And I just want to thank you for being here today.
Appreciate that. I've been saying he has more energy this session. Don't blame me for that. So, thank you.
Other questions, members? Thank you for being here.
Thank you.
Chair calls Chad Carroll.
Good morning, Madam Chair. Yes, ma'am, go ahead, I'm sorry.
Registered as Chad Carroll, and you're representing Donate Life Texas, and you're for the bill, is that correct?
That's correct.
Already, please.
Madam Chair and committee, thank you, committee members, thank you for the opportunity to speak on this bill, and thank you to Representative Oliverson for bringing this measure forward, sir. I'm Executive Director for Donate Life Texas. There's a state of Texas's state legislature established nonprofit organization that manages the state's organ, eye, and tissue donation registry. We also have the mission of educating and informing Texans on donation. So most Texans are familiar with us, as Representative Oliverson spoke, when they go get their driver's license renewed. We get about 90% of our organ donation registries through that process. But although we execute and maintain this quote-unquote deceased registry, we're in the business of educating and informing Texans on all things organ donation. And it's clear the need for kidney transplants in particular is urgent. Currently, just shy of 10,000 Texans are awaiting a life-saving transplant. And as previously discussed, the vast majority, approximately 85% of those are for a kidney. So if we're serious about saving lives, we must address kidney health and transplant opportunities holistically. If we solely rely on the deceased registry that we run with Donate Life Texas, we're fighting an uphill battle to save thousands of Texans' lives. And we must leverage and embrace living donation as well. And this legislation will help us do that. So we're eager to execute the provisions of this bill. We'll readily update our communication efforts to include key elements on living donation opportunities. And thank you again for the ability to come speak with you today, and pending any questions you may have.
Question, members? All righty, thank you.
Thanks.
Is there anyone else wishing to testify on, for, or against House Bill 2826? Chair recognizes Representative Alverson to close.
Thank you, Madam Chair, and I close.
If there's no objection, House Bill 2826 will be left pending The chair hears no objection. House Bill 2826 is left pending without objection.
The chair lays out House Bill 2462 and recognizes Representative Click to explain the bill.
Thank you, Madam Vice Chair. In 1997, Congress passed legislation requiring the FDA to develop a standard memorandum of understanding for state agencies with jurisdiction over pharmacies practicing interstate distribution of large amounts of compounded prescriptions. The purpose of the MOU is to share complaint information about compounders who send more than 5% of their product out of state amongst the other state agencies. There were 3 drafts of the MOU released by the FDA between 1997 and 2020. In October of 2020, the FDA issued a final MOU and made it available for signature by the states. Shortly thereafter, there was a lawsuit resulting in the MOU being remanded by the court and the FDA agreeing to issue a notice of rulemaking in September of 2021. The FDA has stated they intend to issue the proposed rule in October of 23, but it is unclear what changes the MOU will have to the 2020 version. House Bill 2462 would add exceptions to the Occupations Code for the Texas State Board of Pharmacy to disclose certain complaint information with other enforcing agencies. Without House Bill 2462, should the MOU be finalized this interim and include a requirement to share certain complaint information, the Texas Pharmacy Board would not be able to sign the MOU, and compounders in the state of Texas would be unable to ship more than 5% of their product out of state. House Bill 2462 is a permissive bill that would allow the Pharmacy Board to consider signing the MOU if the conditions to share complaint information are still included. Nothing in this bill would require the Pharmacy Board to sign the MOU. It would only make consideration possible if those requirements are still in the final MOU from the FDA. I do have a resource witness to walk through this complex issue and answer any questions you may have.
Any questions? Thank you. If there, we'll proceed to testimony, and the chair calls Craig Chick. Thank you for being here. I show that you're registered as Craig Chick, and you're with Ritchie Specialty Pharmacy, and you're against the bill. Is that correct?
Yes, ma'am. Thank you for the opportunity to come and testify regarding House Bill 2462. My name is Craig Chick, representing Ritchie Specialty Pharmacy, and we are reluctantly opposed to House Bill 2462. Madam Chair, in your layout, you explained the history of this very eloquently. We do appreciate the permissiveness of the bill. However, because there's no MOU that even exists, we think that the legislation is somewhat premature. The FDA in several of these different MOUs has attempted to try to grab extensive authority over state-run and regulated compound pharmacies. And for that, we are very concerned about potential roadblocks that are set at the Board of Pharmacy currently regarding their FDA oversight of our state compounding pharmacies. This stuff's been going on since 1997. There was an advisory committee that was created a couple of years ago that did review the most recent MOU that was released. That advisory committee did come back with a negative recommendation on signing the MOU. The Board of Pharmacy, which is pretty much made up of virtually almost all the same members, I think there may be 2 different members on that committee, did reject the signing of the MOU. So we just want to express some caution as we look at this legislation, and do appreciate the opportunity.
Members, any questions? Thank you for your testimony.
Thank you very much.
You're welcome. The chair calls David Poor. Thank you, sir, for being here. I show that you're registered as David Poor. You're with the Alliance for Pharmacy Compounding, and you're for the bill. Is that correct?
Yes, ma'am.
You may proceed with your testimony.
Chairwoman Click, members of the committee, thank you for the opportunity to testify. I'm here on behalf of the Alliance for Pharmacy Compounding. APC is a nonprofit national trade association representing compounding pharmacists, pharmacy techs, academics, suppliers, vendors, prescribers, and other pharmacy stakeholders. APC is strongly supportive of HB 2462, and we appreciate Chairwoman Click introducing this bill. APC sees this as a necessary precaution for the State Board of Pharmacy to be able to sign the memorandum of understanding that was described in the Chairwoman's layout of the bill. A little bit more of the context here. It was stated that this has been a 25-year process at the federal level for FDA to try to get the federal law correct that requires them to work with NABP and state boards of pharmacy on a memorandum of understanding that handles inordinate quantities being distributed interstate by pharmacies. APC supports the bill, and we hope that the legislature will choose to pass it. There is a lot of uncertainty right now about the federal MOU. That is correct. Right now, it's on remand. The agency has indicated that they will issue a new notice of proposed rulemaking sometime this year, most likely around October of this year. That does make it possible that the rule could be finalized and put in place and a new MOU made available for signatures by states prior to the next legislative session, which would be the next opportunity to put the Board of Pharmacy in a position to sign the bill by creating these carve-outs in the confidentiality requirements. There's a lot, as I said, there's a lot of uncertainty still around the MOU. We don't know what the new notice of proposed rulemaking will look like. It will, in all likelihood, contain very similar requirements on reporting of adverse events and reporting of large interstate distributions of compounded drugs. So we don't know what the final MOU is going to look like or whether APC or other stakeholders will support or oppose the Texas Board of Pharmacy signing that particular MOU. But the punitive measures in the federal law that would cap interstate shipments of compounded drugs at 5% is a real patient access problem. That is a great threat. There are hundreds of thousands of patients that are served by Texas compounding pharmacies that ship drugs out of state. A lot of compounding pharmacy has become specialized. Several of these pharmacies are licensed in all 50 states and treat patients in all 50 states. Couple of points. Nothing in this bill would affect pharmacies in Texas that don't ship out of state. This really only deals with interstate shipments of compounded drugs, not FDA-approved products, just compounded drugs. And nothing in the bill, as the chairwoman said, would require the board to sign an MOU. If we get a new proposed rule later this year, and that goes through the federal rulemaking process, and eventually they finalize it as a new MOU available for signature, you know, we and other organizations in the state board will assess the requirements on the Texas board, whether those mandates come with funding or not. So there's a lot of unanswered questions. If they finalize an MOU that, again, exceeds the scope that the Congress gave the FDA, as they have for 25 years, I would anticipate further litigation would probably tie this thing up further. But for now, you know, as I said, the 5% cap is a threat hanging over the heads of Texas pharmacies and the patients they serve. And so we would hope that the committee would pass HB 2462 and put the state in a position to sign if and when we do get a final MOU. I'd be happy to take
Any questions? Representative Jones?
You said two things I just want to make sure I understand. One, this bill only refers to bills that'll be shipped outside of the state of Texas. Is that accurate?
It only applies to pharmacies that compound drugs and ship them out of state, to patients out of state, and really to only those pharmacies that ship more than half of their compounded drugs out of state are those covered by the reporting requirements in the current MOU.
So can you give me a definition of compounding drugs?
Sure. So compounded drugs are specialized, individualized drugs that do not go through full FDA approval, but they're compounded by trained compounding pharmacies in sterile clean rooms that are done pursuant to patient-specific prescriptions. So if there's not an FDA-approved product on the market, compounding pharmacists working with physicians can take active pharmaceutical ingredients obtained from FDA-registered facilities and compound the drugs, think, mortal and pestle, actual mixing of the drug to meet a specific patient need. Sometimes that's done from approved pharmaceutical ingredient, kind of from scratch, so to speak. And other times it's done with an FDA-approved product as the starting point. There may be an ingredient in a drug that a patient is allergic to. It may be a pill form, and you need a liquid route of administration or an injectable. So compounding pharmacists work with doctors to individualize and specialize medicine under the regulatory authority of the Texas State Board of Pharmacy.
So I'm gonna try to give like a one-word sentence of what a compounded drug is. It's a drug that's not FDA approved, but that pharmacists with proper guidance do to try to individualize medication for somebody.
Under the regulatory authority of the Texas State Board of Pharmacy or other boards of pharmacy. Yes.
Thank you.
Yes.
Any other questions? Thank you for your testimony. Is there anyone else that wishes to testify on or for or against HB 2462? If not, the chair recognizes Representative Click to close.
Members, House Bill 2462 merely allows the Texas State Board of Pharmacy to consider signing the FDA's MOU on compounding pharmacies. And if they do, this will allow Texas compounding pharmacies to ship more than 5% of their product outside of the state. Thank you, and I close.
Thank you, Representative. If there is no objection, House Bill 2462 will be left pending. The chair hears no objection. HB 2462 is left pending without objection.
I can start. The chair lays out House Bill 2025 and recognizes Representative Alverson to explain the bill.
Thank you, Chairwoman Click and committee members. Thank you for allowing me to lay out House Bill 2025 before you today. And I should point out that its identical companion is Senate Bill 1040. House Bill 2025 would prohibit an insurance company or any other health benefit plan issuer in the state of Texas from covering the cost of a human organ transplantation when the transplant operation is performed in China or another country known to be participating in organ harvesting. In 2019, the Independent China Tribunal announced convincing findings that China has for more than 3 decades practiced the systemic forced organ harvesting of political prisoners in that country. It is believed that to this point, several 100,000 incarcerated people in China, political prisoners, or what they refer to as prisoners of conscience, mainly Falun Gong practitioners as well as Tibetan Buddhists, house church Christians, and members of the Uyghur Muslim ethnic minority, have been killed by the Chinese government in order to extract from them organs to be sold openly on the market. And members, I want to point out to you that as I've done research on this over the last 2 sessions, I have seen websites for hospitals in China advertising in English and in Mandarin, heart transplant available, donors standing by. There is no way to take a heart transplant from a donor who's standing by unless you plan on killing that person. This is literally the most detestable practice I can possibly think of, where a government would look to its own people as basically an economic resource instead of beings with inalienable human rights given to them by their creator. It is so far from the American experience, it is so far from what is justice and what is right, that I felt compelled, along with Senator Kolkhorst, to file legislation forever and all time prohibiting any benefit plan, regardless of what type of benefit plan, including the Medicaid system, from participating and enriching the Chinese government in its process of essentially monetizing its own people. I have people here that will testify firsthand their experience in these concentration camps, what they've experienced, what their loved ones who are no longer with us experienced. And I would ask you to consider their testimony. I recognize that this bill may seem heavy-handed in terms of government, but friends, I simply don't know what else to do in order to send a message to the Chinese Communist government that the state of Texas simply will not be a part of this kind of atrocity any longer. And with that, I'd like to reserve my right to close, and I would ask for your consideration as my witnesses come forward and share their firsthand accounts.
Any questions? No questions? Okay, we'll proceed to testimony. The chair calls Ruth Lee. She is the translator for Keiji Liu and Sean Bai. Thank you for being here. And just to confirm, once again, Ruth Lee will be translating for Keiji Liu and Sean Bai. Both are with the Southern USA Funlai Dafa Association and behalf of yourself, and both of you are for the bill. Is that correct?
Yes, that is correct.
Okay, you may begin your testimony, ma'am.
Okay, so I'm Ruth. I'm reading the translated testimony for Kejie Liu and Mr. Shan Bai. Good morning, Madam Chair and the committee. My name is Kejie Liu. I am a Falun Gong practitioner from Houston. I'm here to express my support for House Bill 2025. I have been practicing Falun Gong since 1997. After only 3 months of practice, my kidney problems, anemia, and endocrine disorders disappeared. The health benefits of Falun Gong were miraculous. It also helped me gain peace of mind and confidence. After the persecution of Falun Gong began in 1999, I was illegally arrested 7 times. The Chinese Communist Party developed over 100 different methods of torture, and my husband and I experienced a dozen of them in prison. I was also blood tested multiple times without my consent. 8 times through finger pricks and 5 times through blood draws. I later realized these tests were necessary to check the blood and tissue type compatibility between an organ source and the transplant recipient. My family has also suffered because of the persecution. One time, the police took me away from my home without a warrant. For 10 days, I could not take care of my disabled daughter. She couldn't eat or sleep and was constantly staring at the door, longing for my return. My mother passed away due to prolonged terror and worry about my safety. My husband, Shanbai, was arrested 6 times. The first time, he was detained for 37 days and lost 30 pounds due to torture. He was also blood tested many times. In that same detention center, 2 Falun Gong practitioners went missing, likely becoming victims of organ harvesting. His aunt, also a Falun Gong practitioner, was tortured to death. The Chinese Communist Party imposes collective punishment on anyone associated with Falun Gong practitioners. In order to protect loved ones, many practitioners who were arrested chose not to reveal their identities, even at the risk of being detained indefinitely. Unfortunately, this has made practitioners the primary targets for forced organ harvesting. My husband and I are grateful to Representative Oliverson and to all the co-authors. We sincerely request every committee member to support this bill, as it will help Texans make informed decisions on organ transplantation and also prevent them from becoming unknowing accomplices to forced organ harvesting. We truly appreciate your help.
Any questions? Representative Jones.
So where were you taken? You say they took you, and so was that here in the States? Was that somewhere else?
So they were taken away in Beijing, China.
Okay, thank you.
Thank you. Any other questions? Thank you so much for being here. The chair calls Ruth Lee, and she will be translating for Mr. Zhenhu Yu. Thank you for being here. Once again, Ruth Lee is the translator for Mr. Zhenhu Liu, who's with the Southern USA Fanlan Dafa Association, and also on behalf of himself, and he's for the bill. Is that correct?
Yes, that is correct.
Thank you. You may begin your testimony.
Good morning, Chairwoman and committee members. My name is Xinhui Yu. I'm a chef in Austin. I'm here to support House Bill 2025. In 1999, I started practicing Falun Gong, a traditional Chinese meditation practice centered on the principles of truthfulness, compassion, and tolerance. In 1999, the Chinese Communist Party began to persecute Falun Gong, and I was imprisoned for 6 years just for telling others how I benefited from this practice. While in prison, I was severely tortured and also subjected to multiple physical examinations, including urine tests, eye tests, chest x-rays, and blood tests. The amount of blood they took out was enough to fill a tube. I was also asked about my heart, liver, and kidney history. Later, I realized they were actually checking whether I was a suitable match for organ transplants. Everyone in prison knows that there's a list of names. People are taken away, never to return. One night in 2006, I saw several buses, military vehicles, and ambulances parked outside. armed policemen entered the prison and shouted, "Don't look, don't talk, lie down in your bed and face the wall. Come out when your name is called, and don't bring anything with you." Everyone's eyes were filled with fear. 3 of my cellmates were taken away that night. I never saw them again. One prison doctor was from my hometown, and he was sympathetic to my plight. He secretly told me, "You Falun Gong practitioners practice Qigong exercises regularly, so your bodies and your organs are of course the best, because organs from other prisoners might not be good to use since they abuse drugs, alcohol, or engage in other bad habits." He suggested I should pretend to give up Falun Gong in exchange for my life. He said, "Otherwise, who knows what would happen to your heart, liver, spleen, and lungs." I was one of the lucky ones to survive the persecution. After escaping to Thailand, my family was finally granted asylum in the US. But there have been over 4,900 documented cases of Falun Gong practitioners who died due to persecution. The true death toll must be much higher, though, considering countless practitioners disappeared because of forced organ harvesting. More people need to know what's happening in China. I appreciate Senator Paxton and Representative Shaheen for introducing SCR 3 and HR 10 in the last session, which gave me a chance to share my story and bring more awareness of this issue to the Texas legislature. And thank you to Representative Oliverson for House Bill 2025. I strongly hope this bill can pass with unanimous support. Thank you very much.
Thank you. Are there any questions? No question. Thank you for your testimony.
Thank you.
The chair calls Maheb Omar Kanat. Sir, can you please confirm your name, who you're with, and whether you're for or against the bill? And I apologize if I didn't pronounce your name correctly.
Yes, my name is Mahmed Omar Kanat. I'm the Executive Director of the Uyghur Human Rights Project, a research-based advocacy organization which documents the Chinese government's human rights violations against Uyghur people. And I am here to support the House Bill 2025. Thank you for introducing this bill. So, good morning, distinguished members of the committee. Thank you for the opportunity to testify today. The Uyghur people in my homeland are suffering mass roundups, torture, and sexual assault in concentration camps and forced labor. The dehumanization of the Uyghurs by the Chinese government is fundamental to the ongoing atrocity crimes which the State Department has designated as a genocide. This is what Chinese officials have said to describe Uyghur culture and religion. Uyghurs who do not assimilate into majority Han Chinese culture are, quote, weeds that should be, quote, exterminated. They say that the Uyghurs' religious faith is like, quote, an ideological disease, and it needs to be cut out like a tumor. An official said that the government must, quote, break their lineage, break their roots, break their connections, and break their origins. Under these conditions, there is nothing to stop the Chinese authorities from using Uyghurs as a living organ bank. Mandatory DNA collection from all adult Uyghurs began in 2016. Every person taken into the detention camps has a health check by a doctor. The Urumqi airport in the capital city of our homeland, East Turkestan, has a fast-track lane for transporting organs for transplant surgeries. China's organ tourism is a big business because of extremely short waiting times. Some brokers have advertised halal organs to people in Muslim-majority countries. The strong implication is that Muslim Uyghurs could be killed on demand for their organs. The Uyghur genocide is the largest mass detention of an ethno-religious group since the Holocaust. 800 to 1 million Uyghur children have been separated from their parents and taken into the state custody. They are in a so-called orphanages. Where they are raised to be loyal to the Communist Party. Their parents are in camps, in prisons, or factories where they are used as modern-day slaves, producing goods even for American corporations. I'm very grateful for this committee, for your attention to make sure that Texans will not be complicit in the suffering of my people. Ending complicity in forced organ harvesting is a strong step in ending complicity in genocide, in crimes against humanity being committed by the Chinese government against the Uyghur people. Thank you.
Thank you. Are there any questions? Thank you, sir, for your testimony. The chair calls Shangrit Chahani.
It was a really good attempt.
Okay. Can you please give me your full name, who you represent, and whether you're for or against the bill?
Good morning. My name is Sharik Abdul Ghani, and I am in favor of HB 2025. I'm the executive director of Minaret Foundation, where we bring faith communities together through multi-faith and civic engagement. This is an issue that has powerful implications for religious freedom, and I'm reminded of the Bible in Matthew 16:24, where Jesus said to his disciples, "What good will it be for someone to gain the whole world, yet forfeit their soul?" Inadvertently, due to the understandable needs of Texans who need organ transplants, we're uplifting an industry rooted in evil in China, facilitated by the CCP. I would like to note that we had attempted to bring the Uyghur community here to testify at the Capitol today. However, because of CCP surveillance and intimidation right here in our state of Texas, they cannot because of threats to their family members in China and overseas. This situation has only been made worse after the discovery of a CCP police station just in the last week in our city of Houston, which has a substantial Uyghur community. Committee members, this industry is based on imprisoning Muslims, Christians, and others of faith and brutally removing their organs against their will. These believers are tortured simply because they've been identified as having a faith, a belief in God, which is contrary to the communist system. In our tradition, the Prophet Muhammad, peace be upon him, said, "If you see an evil, change it with your hands, and if you cannot, then change it with your tongues. And if then you cannot, at least change it with prayer." Religious freedom is a cornerstone of our democracy and an innate value we hold as Texans. This bill will go a substantial way in protecting the religious freedom of Muslims and Christians and others of faith by preventing Texans from uplifting a terrible industry in China and other nations that forcefully remove organs from its population. As Texans, we have a real opportunity to lead on this issue. Thank you immensely, Chairman Oliverson, for this bill. May God bless you, God bless you all, and allow this bill to become a light of hope for victims all over the world.
Thank you. Are there any questions? Thank you for your testimony.
Thank you all.
The chair calls Hai Shin. Thank you, ma'am, for being here. Can you please confirm your full name, the organization that you're with, and whether or not you're here on behalf or against the bill?
Yes, my name is Hua Chen. I'm a Falun Gong practitioner from Houston. I'm here to support HB 2025.
Thank you. You may continue.
And she's representing herself.
And you're representing yourself as well, is that correct? And the Southern USA Fanlan Dafa Association, is that correct?
That's correct.
Thank you, ma'am. You may proceed.
Good morning, Madam Chair and committee members. Before the Chinese Communist Party began persecuting Falun Gong in 1999, there were over 70 million people practicing Falun Gong. But the Chinese regime considered Falun Gong's huge popularity and revival of traditional values as a major threat to its political power and communist ideology. I was in my late 20s and at the prime of my life. But because I refused to give up my belief, I was sentenced to 4.5 years of forced labor without a trial. My mother, also a Falun Gong practitioner, was arrested and tortured in the same labor camp. The guards once shot her armpit and inner thighs with electric batons for nearly 2 hours until she fainted. They even poured water on her to intensify the shocks. She died after her release because of the persecution she suffered. She was only 63 years old. At a detention center in Guangzhou, I was pinned to a concrete floor and force-fed with all salt mixture, which nearly killed me. At a detention center in Hebei province, I was handcuffed to a radiator pipe for 3 days while a police chief groped my body. At another detention center, a guard threatened to send me off to a place where I would be raped. In the labor camp, I was subjected to multiple medical tests, including EKGs and blood tests. Only Falun Gong practitioners were systematically blood tested. These tests were not done for our well-being because we were also severely tortured. Later, I learned that this blood test was a prelude to organ transplant matching. Had my blood type and tissue type been a match for an organ recipient, I would not be here today. This is how Chinese Communist Party established a huge bio database for organ matching. This large pool of detained Falun Gong practitioners could be killed on demand, which enables China to promise short waiting times for organs. China has become the #1 destination for transplant tourism, attracting patients from all over the world, even patients from Texas. As Dr. Howard Monser testified before the Senate last month. I shudder when I reflect on how I nearly became a victim. Thank you, Representative Oliverson, Senator Kolkhorst, and all other co-sponsors for this bipartisan and bicameral legislation. Today, a few Falun Gong practitioners from Austin, including survivors of the persecution, are here to support this bill. Tomorrow from noon to 1 p.m., more Falun Gong practitioners from Texas will gather here at the Capitol South steps for a rally to call for an end to the persecution and for the passage of this bill to make it a law. If Texas can take the lead on this issue, then other states will soon follow. Thank you very much for your help.
Thank you so much for being here. Any questions? Thank you for your testimony. Is there anyone else here to testify on or for or against HB 2025? If not, the chair recognizes Representative Oliverson to close.
Thank you, Madam Chair. I think those of you that know me know I'm not easily perturbed, but I just can't believe what we just heard. And I know that's just the tip of the iceberg. So, I mean, this to me is just some almost science fiction, you know, Adolf Hitler kind of stuff. Unbelievable to think that this is still going on in the 21st century. If it were in my power to overthrow that government and replace it with a government that actually treated people as human beings, I would in a heartbeat. But save that, I would simply ask for your favorable consideration as Texas takes a stand, and that we basically say no more organ trafficking for Texans, no more Chinese organs that were stolen from dissidents for the purposes of enriching the government, no more halal donors standing by, no more Falun Gong practitioners in prison waiting for their number to be called for the police to come and get them and take them away, never to be heard from again. This is an unbelievably detestable practice. And I hope that when this bill comes to the House floor that there'll be unanimous support for this, because I can't think of a single reason why we shouldn't take the strongest stand possible as Texans and unite with these people in their fight for freedom, not just for themselves, but for their loved ones who may still be at risk of being killed in their home country of China. So with that, Madam Chair, I just ask for your favorable consideration, and I close.
Thank you, Representative. If there is no objection, House Bill 2025 will be left pending. The chair hears no objection. House Bill 2025 is left pending without objection. The chair lays out House Bill 2506 and recognizes Representative Jatan to explain the bill.
Thank you, Chair. Members, I'm here to lay out House Bill 2506, which seeks to reduce uncertainty regarding the appropriate process for emergency detention of an individual experiencing a mental health emergency. This bill ensures a person is in protective custody receives the appropriate screening, examination, and treatment at the correct facility for their circumstances. Currently, the Texas Mental Health Code permits a peace officer to take a person with mental illness into protective custody if, because of mental illness, there is a substantial risk of serious harm to the person or to others. However, the code does not sufficiently address the transport, preliminary examination, and detention of a person once the person is taken into protective custody. This can lead to uncertainty for peace officers, unnecessary delays, and complications when screening, evaluating, and providing appropriate treatment to those in protective custody. House Bill 2506 clarifies the order of priority for location and of treatment of an individual experiencing a mental health emergency and outlines best practices for courts with jurisdiction over emergency mental health matters. House Bill 2506 clarifies the definition of an inpatient mental health facility, and where a person must be transported once taken into protective custody by a peace officer. The bill permits a peace officer to also transport a person to a facility for stabilization of a physical emergency medical condition. This clarification reduces uncertainty as to the appropriate location for transport and ensures that the person in protective custody receives the appropriate screening, examination, and treatment at the correct facility for their circumstances. The bill confirms that a judge or magistrate has the discretion to issue an order of emergency apprehension and detention to have the individual transported to the inpatient mental health facility or mental health facility. This ensures that if the person needs stabilization of a physical emergency medical condition, that the treatment is both available to and not a restriction of a person being assessed for the need of mental health services, if determined necessary by a judge or magistrate. Lastly, the Office of Court Administration of Texas Judicial of the Texas Judicial must develop a method to ensure that a judge or magistrate is available every hour of every day to respond to applications submitted by a physician for an emergency warrant or for the detention of a person that, because of mental illness, presents a substantial risk of serious harm to the person or to others. The committee substitute removes the 100-mile provision and allows a peace officer to transfer the apprehended person to emergency medical services personnel of an emergency medical service provider. Additionally, the committee substitute ensures that a person apprehended is told orally in simple, non-technical terms of their rights at the time of the person is being admitted to a facility and for the person is questioned, and before the person is questioned, assessed, and examined. At this time, I'm happy to answer any questions. Did we lay out the committee sub? Are we able to? Okay.
Yes. Chair offers a complete committee substitute.
Thank you. And with that, I'm happy to answer any questions. Otherwise, reserve the right to close.
Questions? Representative Jones?
So this bill would, when somebody gets taken into custody, they would be taken to a mental health facility.
Unless first there is physical medical needs that may need to be met.
So then so my question, so I know we have a facility in Houston, and I know that they don't have enough beds. I know there's like a huge waiting list. It's taking people forever, and they have people that are already there. So, like, what happens if you take someone who's, I guess, doesn't have medical needs there, and there are no beds, or there have been people waiting in line for however long that were there before the people got taken into custody? How does that work? Do they jump ahead of the people? Because some people already have like mental health crises, right? But it doesn't matter. They don't have sufficient space and they gotta wait. So that doesn't seem good.
And so I think we have some experts expert witnesses are gonna be able to talk to that better, but we do have crisis intervention beds, which are designed specifically for those crisis situations when someone's having a mental breakdown. And so some of what we're, it's hard to speak about the budget, but there is concerted efforts to make sure that there's databases and technology there to for law enforcement and magistrates to be able to understand where the mental health beds, crisis intervention beds are. But when there is someone going through a crisis, mental health breakdown, we need to have beds, and that's where they should be taking them.
Like I say, I understand that, but I'm saying there are people that are having mental health crisis, and there's just like literally not a bed, and there's just like no bed, and they'll end up putting those people on a wait. Because I know I had to try to pull strings for somebody. I've had this happen in my law practice, where I had a client who was literally having a crisis, and I was trying to help him get in. So I guess they didn't get in because there wasn't a bed. So my concern is that somebody who may be having a crisis after my person had a crisis then gets the bed that my person who had a crisis didn't get because there weren't beds available.
I think that we're going to have some expert witnesses who are going to be able to talk to that better. The idea with these crisis intervention beds is typically to stabilize them. And once they're stabilized, the further mental health services they get kind of comes outside of that situation.
Okay, I'm going to wait for the resource. Thank you.
Representative Collier?
And so this is a question, but you're probably not going to be the one to answer it, but I'm going to say it so that the resource person will know what I'm going for. So if someone is being detained by law enforcement, they would potentially, and they're having a mental health crisis, if there's not a procedure that the local entity has in diversion for these individuals, they would be taken to jail perhaps. But in that situation, the person may be competent at a point to where they could get bail and be released faster than this procedure, because I'm not sure. I know that in order to commit someone, there has to be a procedure in place. I don't know if your bill is removing that procedure, even though they're in custody of law enforcement. But would that procedure for commitment still apply? And That's all I wanted to know.
Yeah, and I'll let one of the witnesses answer, and then if it's not answered by then, I'm happy to clarify more.
Okay, thank you.
Thank you. The chair calls Lee Spiller. Lee Spiller. The chair calls Jose Gomez.
Sorry, I was checking the time.
Thank you for being here. It shows that you're registered as Jose Gomez and you're with the Harris County Sheriff's Office and you're against the bill, is that correct?
Yes, ma'am.
You
Sorry.
may begin your testimony.
Okay. Good afternoon. It's already past 12. That's fine. Checking the time, but thank you for having me here today, Madam Chairman and committee members. A lot of progress has been done in the last 20 years through CIT training mandated by the state. With CIT training and diversion, we've been able to divert thousands every year since we put that in place, or y'all put that in place. Limiting the facilities police can access may impede access to care. Creating more barriers and overwhelming already stressed systems will not ensure those that need help will get help. Regular hospitals play a key role because there are not an adequate number of crisis drop-off facilities in the county, across counties and the state. We believe that this might have unintended consequences. One of those things is when responding to somebody who's in a mental health crisis, when police come in contact with an individual, sometimes there's hours spent on scene to try to de-escalate that individual. A lot of time and a lot of empathy and a lot of connectedness have gone through calming that individual and finding an adequate place for that individual. Already right now, with the current system we have in place, officers are spending 2 to 4, 5 hours at a regular hospital for a psych bed. Restricting us on where we can place these individuals is going to put more strain on police departments and the citizens we serve in the community. It will become a public safety issue. Officers not only diverting these individuals, officers will be discouraged also to divert individuals. As you mentioned earlier, it might be easier if they have committed a low-level nonviolent misdemeanor, as 1849 discusses, that they would be going to jail. Right now, we have things in place where we're able to divert these individuals and get these individuals the appropriate care. Imagine this: you have an individual who's 18 years old and they're having their very first mental health crisis. And the police officer responds to that situation, knowing in their head that after this is done, now we have to find an adequate place to find this individual, put this individual at. The reality is that with the current places that we have in Harris County, Houston, officers are waiting 2 to 4, 5 hours, even at a regular hospital. We understand the reason of having appropriate psych facilities, but that's just not the reality right now. We had a meeting with one of our local hospitals, and just in Harris County alone, one hospital accepted over 4,000 emergency detention orders. That's just one hospital. And we have about 26 municipalities in Harris County who all are filing emergency detention orders across Harris County. I spent 7 years in the crisis intervention response team, where it pairs a mental health peace officer with a therapist in the car. I had hair because I had 7 years with a therapist in the car. It helped out. But I can tell you firsthand that this types of situations are happening, and we really understand that it is important to find these individuals appropriate care, but we also want to make sure that we have those places in place.
I just want to.
Any questions, Representative Collier?
Thank you. Just want to ask you a question about, you said that there is like a cooling off center that law enforcement can use in Harris County?
Yes, ma'am. Our local mental health authority has what they call a neuropsychiatric center. But as Representative Jones mentioned, they have not that many beds, and you're looking at a county that's exceeding 4.5 million, where not only Harris County is taking people to this place, but outside counties are coming into Harris County.
Okay, and is that for everyone, or they're just for low-level offenses?
So the neuropsychiatric center is for individuals who are in a mental health crisis with no physical issues. A mental health crisis is a medical issue. It's not, separate from any other issue. It's a medical issue. But these types of psych facilities accept individuals that do not have any type of other medical issue, like maybe blood pressure issues, diabetes, things of that nature.
Because the concept behind the bill, it sounds really great. I do like the concept. It's trying to divert people into the criminal justice system and maybe get to the medical issue that is actually happening. So I do believe that this is something that's necessary, but we just need to find that middle ground where we can work together on it.
Yes,
Thank
ma'am.
you.
Yes, ma'am.
Representative Jones?
I was just thinking of the issues I've seen with my own eyes personally. You have an officer who makes the scene. You've got, for example, in Houston, you've got the sheriff's department, you've got a multiplicity of constables. So there's all these law enforcement agencies. You're having somebody who has a mental health crisis. Everybody's got to take them. Because I think our facility is what used to be MHMRA in Harris County. They may have changed the name. With like the regular hospitals, when someone who's charged with a crime is taken because they're having medical issues, I've actually been there and I've seen how long they're just there, just sort of babysitting the person that's having the medical issues. So then we'll be taking law enforcement off the street until something becomes available. If it becomes available, seems to me, excuse me, that would cause potential problems on the street. Plus, I know that at least in Harris County, that they're undermanned with HPD, with the Sheriff's Department, with the different constables' offices. So you're taking even more people off the street. I just see that as a bottleneck of some sort.
Yes, ma'am, and that's our worry about this bill, that it limits where we take this individual. It also go against EMTALA, where EMTALA allows you to take these individuals where they can get that immediate assistance. So if we were to go to, for example, a hospital in Houston that doesn't have an attached psych ward, this bill is saying that the peace officer would be violating that by taking that individual where EMTALA is telling us that we can't take that individual. But let's say if we don't take that individual to the nearest hospital, and we go to the neuropsychiatric center, or we go to Bentop, and this is across the state. We've talked to other agencies as well, where similar issues have come up. That officer, as you mentioned, will be waiting for hours. So, for example, like our psych center is not only intaking these 26 different police departments in Harris County, but outside police departments outside of our county are coming into our county, and now you're waiting 6 to 7, 8 hours to admit somebody, unless they have a physical issue or something like diabetes, high blood pressure, where you have to go to a hospital and get them really medically cleared.
Thank you.
So I just kind of want to make a statement because I agree with Representative Collier that I think it's a good bill, and I would really appreciate you working with the author, because I myself do a lot of work in my community with homeless individuals, and the majority of them have mental illness. And the thing about that is sometimes they can be violent. And I've actually seen it firsthand, but I do understand where you guys are coming from. So there's got to be a way that we can balance it and do more for these individuals, because quite honestly, with the mental issues that they have, it's sometimes inhumane with the way that they are out in the community, the way that they live, their actions, and it's just not fair. So I think that we need to, do more, and this is the time to do it, because I know it's part of the governor's, one of his priorities with mental health. So yeah, I would just appreciate you working with the author, and thank you for all that you do.
Thank you. Yes, ma'am. And we've tried to, even do what we call total diversion as resolved on scene by implementing our telehealth program, where deputies have direct access via FaceTime with a clinician out in the field who can help them determine what to do with this individual, opposed to take them to the hospital, because that might not be the most appropriate thing. But this clinician also helps with hospital beds as well. So if this individual is found to be in a crisis, that clinician on the other side, which is one of our local mental health authority clinicians, helps in trying to the middle person in trying to say, okay, we have a hospital bed here for you, or whatever have you. And we have about 14 different participating agencies in Harris County that trying to, better divert these individuals. And I do want to thank y'all for the CIT training. I did hear that bill earlier. That's something we're doing at the Sheriff's Office already, where we're training more in crisis intervention.
Thank you. Any other questions? No? Thank you for your testimony.
Yes, ma'am.
The chair calls Stephanie Uraciano. Thank you for being here. I show that you're registered as Stephanie Uraciano. You're with the Memorial Hermann Health System, and also on behalf of yourself, and you're for the bill, is that correct?
That's correct.
And I'm sorry if I mispronounced your name, you can correct me.
So Chair Clegg, Vice Chair, and members of the committee, good afternoon. My name is Stephanie Arasano. I'm the manager for behavioral health services for Memorial Hermann Health System, here on behalf of Memorial Hermann and myself in support of House Bill 2506 by State Representative Jatan. First, I would be remiss if I didn't thank Representative Jatan for hosting a mental health stakeholder meeting in Fort Bend County during the interim. There, we discussed this issue with various community leaders, including the LMHAs, law enforcement, county officials, judges, JPs, and acute care hospitals such as Memorial Hermann. Many of the gaps and lack of clarity in the current statute we discussed during that very long stakeholder meeting are outlined in House Bill 2506, such as the definition of a mental health facility and the appropriate venue of care to bring this vulnerable population. Allow me to share an example of the challenges faced by our acute care hospital emergency departments in the current situation. Multiple behavioral health patients arrive to our ERs under EDOs each and every day. At one specific Memorial Hermann campus ER last June, on the 17th and 18th specifically, there were a total of 9 different behavioral health patients brought to that one ER on EDOs in a 36-hour period. This is in addition to folks who walked in. These individuals arrived at that same ER with a variety of presentations, including suicidal or homicidal thoughts, symptoms of psychosis, suicidal gestures related to stressors, intoxication, medication overdose, and self-harm by laceration. Out of those 9 patients, only 3 had a minor need for medical screening and care in the ER setting. This means that there were emergency department resources devoted to 6 patients over those 2 days who did not require any medical care. Had those 6 patients been taken directly to a psychiatric facility, it would have allowed the ER staff to care for additional patients from the community who have acute medical needs. Some of the patients who do present on these EDOs are able to be evaluated and discharged, but others end up being boarded in the ER while we wait and search for accepting psychiatric facility, which can at times take multiple days. The ER is not a comfortable environment for anyone, especially someone who is in a crisis and that might already be on edge. The patients are left on uncomfortable stretchers in rooms devoid of any personal belongings and with very limited, if any, access to appropriate stress-relieving coping mechanisms. The nurses and other staff in the ERs do their best to keep the patients comfortable and calm while also caring for their acutely ill medical patients. However, workplace violence continues to be a growing concern with the increasing number of behavioral health patients brought to the ERs where they're not able to get the behavioral health specialized treatment that they need. For each patient who does not need medical intervention, the appropriate venue of care would be to bring that individual directly to a psychiatric facility whenever possible. Lastly, once a bed is finally secured at an accepting psychiatric facility for those patients who were boarding in the ERs, the varying court procedures in each county in the state, as well as limited access hours to judges and magistrates, can cause further delays in transitioning patients out of the ER and into the correct level of care.
Ma'am, I'm sorry, your time is up.
Yeah, in closing, I just want to thank you guys for the opportunity to testify, and I'll be happy to take any questions.
Any questions? No questions. Thank you so much for being here. The chair calls Lee Spiller. Hello, so I see that you're registered as Lee Spiller and you're with Citizens Commission on Human Rights and you're against the bill. Is that correct?
Yes, ma'am.
You may proceed with your testimony.
Great, thank you. First, I want to appreciate Representative Jatan. Just thank his staff for getting us the committee sub. It's hard to testify on something when you don't know the current version. Also, thank you very much for the Miranda warning in the bill. It's unconscionable that we can question people without them knowing that what they say could lead to their commitment. It's absolutely unfair. We also like access to the courts 24/7. We do think that if you're going to have access to the courts 24/7, then you should also be able to release patients over the weekend and on holidays, because right now they are held. It's like that detention time just doesn't count. We do have, within Section 4 of the bill, we have concerns about the potential for serial detentions. When you're detained, you're not going before a judge. You're not being able to defend yourself. You're just in this limbo while they observe you. And then that converts to an order of protective custody, and then it's another 72 hours before you come before a judge. That continuum of detention, OPC, commitment, while we don't really like seeing people get committed, there is this thing of, well, this is your opportunity to come before a judge. We have sent your office some clarifying language that hopefully will give a way to prevent those where possible. And then we agree with the last witness who talked about people languishing in the emergency rooms. It's a horrible setting for a mental health patient. They do need to be medically cleared though. But yeah, the last thing we want is to see people boarded in emergency rooms. Let's see here, LMHAs, they actually need to be the gatekeeper. LMHAs have a lot of responsibilities, including making sure that there is an appropriate setting and coordinating care. If we don't have them coordinating the care, who's gonna do it? If the LMHA doesn't say whether a setting is appropriate, are we gonna leave it to a physician who may have a financial stake in that patient's care? We don't wanna do that. Those were our concerns with the bill, but like I say, we would like to work with your office to get those addressed. Thank you very much.
Any questions? Representative Collier?
Thank you, Lee, for this clarification and recommendations. Are you saying that the bill does not give the person credit for time served throughout this process of medical or mental health crisis?
If your detention expires over the weekend or on a holiday,
okay,
it's told until 4 p.m. the next business day. So literally, I've had somebody who went in on Thanksgiving Eve and didn't get out until the next Monday.
Okay.
And actually, he ended up staying the next Tuesday because the social worker had already
taken off
gone
work.
home. Yeah.
Okay, and that's current law, though?
Yeah.
Okay, but you're asking for that to change?
Let's go ahead and change that. Since we're going to create access to the courts anyway, there's no excuse. The only excuse for holding somebody over the weekend or on a holiday in that case would be physician coverage. And I'm sorry, if you're in the hospital, you deserve physician coverage.
Okay, makes sense. Thanks.
Thank you.
Thank you. Any other questions? Thank you, sir.
Thank you.
The chair calls Haley Valdez. Thank you for being here. I show that you're registered as Haley Valdez. You're here on behalf of yourself and you're against the bill, is that correct?
Yes, that's correct.
You may proceed with your testimony.
Thank you for giving me a chance to speak on this bill today. I was with the suicide hotline for 7 years. When receiving calls at the suicide hotline, my most common hesitation in callers was going to the hospital or giving out their information because they don't want to be put into a hospital or mental facility. Many of them have already had bad experiences where they felt trapped. And I can relate. In the summer of 2020, I myself was held against my will at a mental health facility. I had gone on my own after talking to my therapist about suicidal thoughts. But when I arrived, I was treated more like a prisoner. I was stripped down, told to squat and cough, and my medical devices, which helped me walk, were taken away from me. This meant I could only sit in my room by myself because I am a fall risk. I saw people who had been stuck in there for months. Some didn't even have mental illnesses that I could tell. Many were being physically mistreated by staff. I recall an older woman with stomach cancer being told to shut up and thrown into her room because she was being too loud after asking for her dose of medication because she was having stomach pain. I still think about her often. I felt like every day my mental state was getting worse and I just wanted to go home. But when I told staff, they said if I tried to leave, a judge would make me stay longer. Finally, a couple days later, I was abruptly let out with no warning and no plan. I was able to give my ride about 25 minutes notice and not allowed to say anything to anyone in the facility. I remember getting home and knowing I was lucky because I had my voice and I had people fighting for me. But there were still people in there that were stuck, and all they could do was wait, which could be another 2 months since the courts are closed on weekends, holidays, and emergencies. And this was during COVID. Many of these patients were stuck in there for long periods of time with no idea when they would go home. Reading through this bill just reminds me of my stay at this facility where I felt hopeless and scared when I should have felt safe. I'm scared for everyone else who is trying to find treatment and will be met with the same trauma I found. We deserve better treatment, better resources, and better bills. Please keep in mind the effects this will have on real lives if this is passed. Thank you again.
Questions, members? Thank you.
Thank you.
Chair calls Jan Lightfoot. I show you registered as Jan Lightfoot, and you're representing yourself, and you're against the bill. Is that correct?
That's correct.
Okay, please begin.
Thank you. Good morning to all of you honorable persons and Madam Chairman. Chair, I am here to say thank you for the good aspects of the bill, but to offer suggestions that would improve it. I'm a mental health professional with a mental health diagnosis from an occupational injury while working for the federal government. And I have 52 years of experience. I am a proponent of detentions that are needful, but I'm here to speak against systemic, illegal, involuntary commitments that I was a victim of myself under Texas authority, judicial authority, in December 2018. At that time, my grandson was visiting with me. He was 14. And I had a headache and didn't want to drive. So I went to get an injection for a headache, and I was held in a mental health facility and misdiagnosed as a person with a delusion. I never saw a doctor. There was no description of a delusion. There was nothing to suggest. No one answered me about what was the delusion, and my insurance was billed for services that were never rendered. So I'm concerned that this bill does not have enough safeguards against these kind of occurrences. My constitutional rights and all standards of law were violated, and I was received no protection. I was sexually assaulted, given a lethal dose of dosage, prescribed lethal dosages of medicine that would have killed me. When I reported the sexual assault, nothing was done. I was accused of offering myself to the judge. So my constitution, the only criteria for this was that I am a person with a mental illness. However, and the ands, because of the mental illness, there is a substantial risk of serious harm to myself or others unless I was immediately restrained. That was not present. And there was not significant time to attain a warrant before taking me into custody. I drove myself to the hospital. We want to say that the constitutional standard for that is the U.S. Supreme Court that says if you have someone who can take care of you, you should not be detained. My god sister was there the whole time asking for me. They would not release me because they profiled me as a person with good insurance. On February 23rd, a HPD officer, this is 2023, this happened in 2022, made a wellness visit asking my now 18-year-old grandson, who was 14 at the time, who was also deprived of seeing me because I was blamed as being a crazy lunatic. So he was, when he turned 18, he came back to live with me.
Your
So,
time's expired.
okay.
Can I ask a question?
Any questions?
Yes, I just want to ask a question about, were you afforded an attorney to represent you during this process?
She
being
did not
detained?
represent me.
But
I
were you
did not
afforded
waive
one?
my rights to see the judge. I never saw a judge, I never saw a doctor. Medicare has since declared it as a fraudulent and took back the money.
Okay, but during the process, were you afforded an attorney to represent you for the detention?
The attorney did not act on my behalf.
Okay, but you were afforded, I just wanted to see if that was in the process. I hear you.
It was in the process, but it was a futile process.
Okay, I got you. All right, well, thank you for shedding light on this issue. I appreciate you.
Okay, thank you.
Thank you. Chair calls Lee Johnson. Next on deck will be Christopher Canaster. I show you as Lee Johnson, and you are representing the Texas Council of Community Centers, and you're neutral on the bill.
Yes, thank you, Madam Chair. Lee Johnson with the Texas Council. I'm testifying on House Bill 2506. I want to say thank you to Representative Jatan for his interest in these issues and for the changes that have been made in committee substitute, but we still have significant concerns and believe the bill could lead to some unintended consequences. In Section 1, it revises the definition of inpatient mental health facility and mental health facility from an identifiable part of a general hospital to a mental health or psychiatric unit of a general hospital. We interpret the provisions here and these changes as removing a general hospital without a mental health or psychiatric unit from the list of options in a community that could be considered appropriate for treating a person who's experiencing a mental health crisis or mental health emergency. Many communities across the state lack access to appropriate mental health or psychiatric units equipped to address these emergency situations. So ensuring persons can access emergency care at a general hospital has been really important. Our system has also been involved, the local mental health authorities, in developing diversion strategies to transition folks who access emergency care in a general hospital to more appropriate locations, but those diversion strategies are not available in every community across the state. We hope the investments proposed in the budget, particularly those investments for the grant programs, for the justice-involved folks and for the mental health grant program, will provide additional resources necessary to support communities in creating more diversion options for people experiencing mental health emergencies. In Section 2, we really appreciate Representative Jatan removing the 100-mile language from the bill as filed, but we have concerns about the removal of D1B. That section of law has permitted the local mental health authorities to identify general hospitals as being appropriate for continuity of care when no other options are available in the community. An example would be a patient on emergency detention at a general hospital, and the permitted time for that order, 48 hours, is about to run out. The local mental health authority and the courts work together to extend this time when it's appropriate by seeking order of protective custody for the individual. If the LMHA has designated that general hospital as appropriate, then the judge can order the OPC, the order of protective custody treatment, take place at that general hospital when no other bed at another inpatient facility is available. Again, this is necessary because not every community in Texas has access to an alternative mental health or psychiatric unit that's equipped to manage these emergency situations. Sections 4 and 7 are also of concern. Section 4, because it seems to authorize concurrent emergency detentions beyond 48 hours allowed in current law. And then Section 7, because given the change to the local mental health authority role in Section 2 of the bill, it's not clear if the LMHA will have the opportunity to be involved in determining that a person needs to be transported to an appropriate facility. We'll continue to work with Chair Jatan and his staff to make further changes to the bill. Thank you so much for the opportunity to testify. Appreciate it.
Oh, can I ask a question?
Representative Collier.
Oh, thank you, Madam Chair. I'm just looking at, thought about this. I do appreciate the work you guys do. And good point about the mental health or psychiatric unit, because if it is a hospital, general hospital without one, they could probably still provide the care that is needed. Who pays for individuals? Like law enforcement, they're not going to know if they have insurance. They're not going to, know. So if they take them somewhere, that's private, because this is already law, so, but who pays those bills? Does the state pay for that? I don't,
So it depends, and I'm by no means an expert in how all of these services get paid for, but I can tell you for our system, the state agency, the Health and Human Services Commission, takes the funds that are appropriated by the legislature, and the local mental health authorities are able to locally purchase capacity at a private psychiatric hospital, for example. In the budget, that's called the PPB capacity, private psychiatric bed capacity. The legislature has done a great job of increasing access to those locally purchased beds because today, as a result of a number of legislative decisions, the state hospital system is largely, the capacity there is largely consumed by the forensic population, so people in need of competency restoration from the jail. And so those locally purchased inpatient beds are really the only way that people that need psychiatric care are able to get that. That said, however, you know, there are limitations to that. Demand for those services exceeds available capacity. There are probably some other folks here who can talk about more of the nuances in the hospital system. That's outside of my world, but if it's the locally purchased beds, our system is involved in helping to coordinate that and helping to ensure that utilization of those state funds are done appropriately.
okay. Do you know if PPBs get paid or reimbursed at the same rate as the inpatient hospital rate, or the ones that, you know, at the?
Well, that's kind of a totally different issue.
Okay.
But glad to follow up with your office on that to talk in more detail about it. But we have our members that engage with their private psychiatric hospital partners have had continued conversations about that rate falling short. We're hopeful that if the budget passes in its form, that there will be some additional capacity there to address the market factors that drive that rate.
Now,
So hopefully it will come up.
Okay, so it's not paying dollar for dollar the cost it is for these PPBs. By capacity, do you mean, because you just told me that there's not enough. By capacity, are you talking about reimbursing at the actual dollar for dollar rate? Or are you talking about adding more beds?
Both.
Okay.
It's both. So it's bringing that rate up so that we can continue to attract private psychiatric hospital partners to step into this work because there are no other options available. But it's also additional capacity for more locally purchased beds. We need both of those things.
And the locally purchased beds, they can be at private facilities, like a privately owned
Yes, ma'am.
unit. Okay, thank you.
Other questions, members? Representative Copples?
I would just ask if you and I can get together, or we can get together with my staff, because I've got a lot of questions. Again, because I do a lot of work in my community and just trying to figure it all out.
Absolutely. Glad to do that. Thank you, Representative.
Thank you.
Other questions, members? Thank you.
Thank you.
Chair calls Monica Ayers.
I'm gonna stay registered.
I've got to have you come up. Okay, I show you registered as Monica Ayers, representing the Citizens Commission on Human Rights, Texas, and yourself, and you're against the bill. Is that correct?
That's correct.
Okay.
Do believe that this is a well-intentioned bill. There are some great points in it. We do have some concerns that my colleague Lee Spiller did mention. We hope those can get addressed. Did speak to the office a couple of times and would just appreciate continuing to work.
Alrighty. Questions, members? Alrighty, thank you. Christopher Knatzer.
Pretty good shot for the first time.
Knatzer. I show you registered on behalf of yourself and that you're for the bill. Is that correct?
That is correct.
Alrighty, please begin.
Madam Chairperson, members of the committee, good afternoon and thank you for this time to speak with you. I am a partner at Norton Rose Fulbright based out of Houston. This November, I will have been practicing for about 10 years. Last 7 years, I've been doing mental health law specific to these type of issues. And my hope is to clarify some things about the bill that we've heard here today. I think that one of the things that we can all recognize is that mental health is a very difficult issue. We've heard some sad stories of things that have happened to folks. We've heard some concerns about the current Texas Mental Health Code and this bill specifically. One of the things that I wanted to start off with was clarifying that these changes are not changes to the civil commitment process. This is pre-civil commitment process. This is what happens when someone is being detained into protective custody. It won't even necessarily be in connection with a criminal proceeding that will be going on. It is merely addressing a situation where someone is a danger to themselves or others. They're taken into protective custody, and we need a definitional structure and a uniform process for where they can be taken and when they should be taken. One of the terms that we heard about earlier was called medical clearance. Imagine a patient who is suicidal, who has suffered a self-inflicted gunshot wound. Medical clearance would mean we probably need to address the gunshot wound before we address their mental health. The current mental health code does not address mental clearance at all. It's not even in there. House Bill 2506 adds that and makes it clear that in a situation where someone has a physical medical condition that requires emergency medical treatment, that they can be taken to an emergency department. Because the current code only references emergency rooms of a general hospital in one place. It does not include it in the definition of a mental health facility. It does not include it in the definition of an inpatient mental health facility. It just says that if a peace officer detains someone and brings them to a mental health facility or a general hospital's emergency department, that the emergency department can't require additional forms. I think we can all agree that there are good times to bring someone to the emergency room as opposed to a licensed mental facility that can treat something that is solely a mental health illness issue. The other thing that I want to clarify is there's a lot of concern about capacity. How many beds are available? Where should we take them? 2506 separates the concept of an examination from the process of an actual bed for the treatment as they move on towards the civil commitment process. So what would happen is assume for a moment that medical clearance is not needed. Peace officer would detain the individual, take them into protective custody, go as far as is necessary to find a licensed mental health facility. The EDs are not licensed to do this, but they are examined there. They are examined at the inpatient mental facility. Irrespective of whether there's a bed to hold them or to treat them, they will be examined there. At that point, the local mental health authorities, which we all agree have a very important role in this process, will manage resources in the community to make sure that just a mental health facility is at least available to take on these individuals as they go towards the mental commitment process. I could talk all day long. I would prefer to answer any questions because this bill is very important, and I can't tell you how much I support fixing this because I've been helping hospitals navigate this for 7 years now. And the largest issue that we see is even after an individual comes to an ED and there has been an inpatient bed made available, there's not a court or a judge available or willing to issue the transport. That's the other part. I didn't have time to talk about that. But again, I'm happy to answer any questions.
Representative Collier.
Very good. This very good clarifying. So the question I have deals with, so this is when somebody's having a crisis. And this bill would have law enforcement try to find resources for the person to go to the next stage, or would you work with the local mental health authority who knows where the resources are?
So I think the best way to clarify that is to tell you how the current mental health code works. It is very clear that the peace officer must first take them to the nearest appropriate inpatient mental facility.
Mm-hmm.
If there is not one available, then they must take them to a mental facility, not an inpatient mental facility, but a mental facility that has been deemed suitable by the local mental health authority.
Okay.
It's a watershed.
Mm-hmm.
And then if there's not a mental health facility that's available that has been deemed suitable by the local mental health authority, then they have to take them to jail. That's the current stair step of where they can be taken. Under 2506, what is contemplated now is they still take them to an inpatient mental health facility first. But the fact that there's not a bed to hold them is not a limitation on the examination occurring to confirm that this person actually is in mental distress. If at that point that's been confirmed and they need to be given a bed at a location, but it's not available at that facility, then the local mental health authority will coordinate resources for a mental health facility in the community for that person.
So when does the officer get to hand off the person? I mean, is the officer involved the whole time?
So if there is a bed available at the inpatient facility, that would be the handoff.
But if there's not?
If there's not, then the local mental health authority, in conjunction with the peace officer, they'll actually call in a new peace officer to effectuate the transfer from the facility that did the examination to the facility that will hold them that has a bed available.
Okay, because I was just picking up on what Representative Jones had talked about, you know, because then the person is caught up on hours and hours, maybe even longer.
Of course, and one thing that might make that point a little bit clear, as of right now, they are being left in waiting rooms or in triage rooms in emergency departments. So there is no exchange. Under the current code, if it was operating the way that it was contemplated and they were taking them to an inpatient facility that had a bed available, first and foremost, the facility administrator would have to approve them. They would have to consent to them. We heard EMTALA talked about a moment ago. EMTALA is federal law. If they are brought to the emergency room correctly, incorrectly, under the current mental health code, the hospital has no option but to take them. It doesn't mean that the mental health code says they could have been brought there in the first place. It just says if they are brought there and left in the waiting room, then the hospital can't do anything to release them until they're stabilized, which is why they go out and get an inpatient bed somewhere and need the courts to help them make those transfers, whether it be after hours or some other time that's more efficient.
Do you see this as creating a priority system? Like this is the first one, then the second, then the third, this is how you do it? Like a priority, like try this one first. If this one doesn't work, go to this one. Or is it just any one of them can be selected?
So the current code has a priority system, and so does this one.
Okay.
The distinction here is when a peace officer shows up at an inpatient facility and they say, we don't have a bed to hold this individual, that doesn't mean that the officer has to drive to another facility and then eventually dump them at an emergency room.
Right.
Instead, they are examined, and then once it's determined that they in fact have a mental health condition, because they may not, and then that's the end of the inquiry.
Right.
But if they do, the local mental health authority works with them to find resources at a mental health facility that does have a bed available.
So in theory, this would actually put law enforcement back on the beat or
of course,
ground faster.
In full candor to this panel, the only time that it wouldn't be would be if the status quo is you always take them to the emergency room, meaning they never go to the inpatient facility in the first place. And we have experienced that in some communities, unfortunately.
All right, thank you.
Other question, Representative Jones?
Thank you for coming, my constituent. So I understand the issues with having mentally ill people in emergency rooms. I understand that. But there's also another balance because the officers just can't leave them. And I'm thinking of situations, there's always a logjam for me when I'm trying to help this because the jails, quite frankly, are like the largest mental health facility in the state of Texas, right? So people are leaving their offices at 3 o'clock, 4 o'clock, 5 o'clock. So if someone gets taken there, that literally nobody's there to even do an evaluation like you are saying that they're required to do, even if they don't keep them. And so the officers have to stay there with them. And even in the situation where you said where they'll call in another officer, it's just been my experience that the officers, for the most part, are like dealing with like really big emergencies, shooting, whatever. So if you're waiting for another officer to come, whoever's there with the person initially is going to be waiting until an officer is available to handle something, that's not life or death. So how are you considering, when you're saying this, are you considering the different log jams and the different parts of the system, whether it's law enforcement or whether it's hospitals, and then how are you balancing, like, which log jam is the most, has to be prioritized?
Right, so this is why I started with mental health as a difficult issue. I think we would all agree that first and foremost, we need to respect the rights of the individual who is trying to be evaluated, examined, and if necessary, treated in the process. The current example that is happening over and over and over again, whether there are beds available or not, or whether the bed's just too far for the peace officer to drive to, is these individuals who have already been determined to be a danger to themselves or others are released in an emergency room, waiting room, in the general public. All due respect to the peace officers who have other things to get to that they need to do, I understand that, and I understand the resources that we need to affect that. But the current mental health code requires them to take them to an inpatient facility first. All the HB 2506 changes with respect to that is it cuts it down to an examination so that if the person doesn't have a mental health crisis, then they can be released at that point, and then you don't have a peace officer involved. And if they are suffering from an acute mental health crisis, then the local mental health authority can assist that officer in finding more resources. It's just not MHR, MRA that's available. It's not just that facility that might not have a bed. They can go to the surrounding counties and find them a facility that has a bed, which the emergency departments are already doing on their dime, and then bringing in an officer to transfer them. This just allows the local mental health authority to address that at the forefront.
I understand it's difficult, but as I listened to some of the stories of the people that came up here before, you know, the lady who voluntarily drove herself because she was having a crisis, and next you know, she's locked up. The other lady who went to go get headache medicine injection, next thing you know, she's locked up. So it's not as, I mean, I wish there were an easy fix, and it's a difficult situation, but I know for a fact that the mental health facilities don't have enough resources.
So, and I just want to make sure that it's clear, and I may have misunderstood, but in the stories that I have heard here today, they were referring to the mental health facilities where they had been taken. And I want to make sure it hasn't been lost on this panel before I sit down. The emergency department of a general hospital, more often than not, does not have someone licensed to treat these individuals. I understand that there are concerns about the resources at the facilities that are licensed to take care of these individuals, but they are licensed. They are licensed, and they have the equipment, and they have at least the building to address them. The emergency department of a general hospital does not.
I understand the distinction.
People are being injured at these facilities.
I understand.
Significantly.
I understand the distinctions that you're making, but I also know that I don't want to go, I understand what you're saying, it's just very difficult. Hopefully, the authors or whoever brought the bill can figure out ways to balance civil liberties of all involved.
Of course, and I think everyone would agree that them sitting in a hospital room for 5 to 6 days with no way out is not respecting their individual liberties.
That's one. There's some others I just heard, but thank you.
Any other questions?
Thank you.
I thank you so much for your time, and we implore this panel for your vote. Thank you so much.
Is there anyone else wishing to testify on, for, or against House Bill 2506? The chair recognizes Representative Jeton to close.
I am registered. What's her name? Hayes is the last name.
Okay,
Oh,
hang on.
Reese, here she is. Okay. She registered as do not testify. Okay.
All righty. We show your name is Arise Hayes.
Yes.
And you're with Disability Rights Texas, and you're against the bill.
Yes.
I think you had originally indicated that you didn't wish to testify, but you've changed your mind.
Yes, I did,
Okay, please
based
go
on the
ahead.
testimony that we've heard. And I do want to thank all of you and Representative Jeton and his staff
for having spoken with us, and I apologize that we did not have an opportunity to talk with the office about the committee substitute. And we do acknowledge the improvements that are in the committee substitute, as previous individuals have. But we remain concerned about a couple of pieces of the bill, and they've been brought up previously. One of the things that I wanted to clarify, I may have misunderstood, but the Mental Health Code, Section 571.003, does actually define an inpatient mental health facility under E, an identifiable part of a general hospital in which diagnosis, treatment, and care for persons with mental illness is provided, and that is licensed by the department. And in the work that Disability Rights Texas has done with HHSC, that has always been acknowledged as the emergency room. Our concern is that if you take out that language of an identifiable part, you are taking out the emergency room. And I'm asking, well, where are the individuals that are on a warrantless detention or with a warrant detention, emergency detention, where are they going to go? As has been acknowledged, there aren't enough resources available. And I really appreciate opportunities that have been made by the legislature to develop diversionary activities and locations. That's one of the most important things that needs to happen, is to have places where individuals can be dropped off so that law enforcement can go back on the street and do their thing, but the individual has the resources that are available to support them as they're going through a mental health crisis. I don't think that everybody understands what it means to take out that language, an identifiable part. That is extremely important, and I would encourage you to get a legal interpretation. I'm not an attorney, but I do work with one. We are also extremely concerned about consecutive emergency detentions. And in my written testimony, I emailed it to everybody last night, and I brought a hard copy today. The issue with an emergency detention is that there is no due process. You are placed on an emergency detention not to exceed 48 hours. There is an opportunity for the facility to file an order of protective custody, which would be for 14 days with a probable cause hearing within 72 hours. But that's not what's being suggested here. Instead, when that 48-hour term expires, then they could seek a second emergency detention. Well, when does the person get to go to court? There was information from the Judicial Commission on Mental Health that helped to clarify the language, because it isn't clear in statute right now. But the Judicial Commission for Mental Health and Professor Brian Shannon provided some information about that interpretation about consecutive emergency detentions and the problems with that. Quote, the policy concern with consecutive emergency detentions is that an applicant or judge could effectively circumvent commitment procedures and thus due process protections by seeking or issuing serial emergency detention orders under the Texas Health and Safety Code, Chapter 573. So one other thing I want to make clear. I am very concerned that we are focusing on Harris County, or Fort Bend County, I understand, has had some issues with the process. But this is going to impact the rest of the state, not just one county or surrounding counties. And if there is a need for us to do a major revision of the mental health code, then I think that there needs to be more time an opportunity to have a broader stakeholder discussion to address the issues that are being faced across the state, or what is being successfully used across the state, rather than modifying the code to address concerns for one specific area of the state. And I've seen a number of bills that do that, and it causes us a lot of concern, because it is going to impact what happens with individuals with mental illness across the state of Texas. I'd be glad to answer any questions you might have. Thank you.
Thank you. Is there anyone else wishing to testify on, for, or against House Bill 2506? Chair recognizes Representative Jeton to close.
Thank you, Chair. I know that we're getting close to session beginning, and so I know we need to wrap up. I do want to thank you for the opportunity to lay this bill out. This was a bill that we put together with a lot of stakeholders that some of them do deal with outside of Fort Bend County and Harris County area that recognizes that we need a process in place that makes sense across the state. We can't have a patchwork system of inconsistencies, and so I appreciate the testimony that's been given and the work of the stakeholders and also the other counties around the state that have expressed support of this legislation. And so with that, I will happy to answer any questions, otherwise I close.
The committee substitute is withdrawn. If there's no objection, House Bill 2506 will be left pending. The chair hears no objection. House Bill 2506 is left pending without objection. Members, that concludes today's agenda. The chair moves to adjourn. Is there objection? Hearing none, the committee stands adjourned, subject to the call of the chair.